I'm Dr. Lee Frame, and I will be your host today. I lead the Integrative Medicine programs and the Office of Integrative Medicine and Health, as well as the Resiliency and Wellbeing Center, here at the GW University School of Medicine and Health Sciences. And I'm really thrilled to welcome you to the Office of Integrative Medicine and Health's 7th Annual Sung Symposium. It's actually kind of hard to believe we're already in year 7, but here we are. So first, a little background on integrative medicine in general and here at GW. So the definition of integrative medicine is that integrative medicine and health reaffirms the importance of the relationship between practitioner and patient, focuses on the whole person, is informed by evidence, and makes use of all appropriate therapeutic and lifestyle approaches, healthcare professionals, and disciplines to achieve optimal health and healing. And since 1998, the GW Center for Integrative Medicine, founded by John Pan, has served the Washington, D.C. metro area, including as a training site for the GWMD program and fellowship in integrative medicine and integrative geriatrics. In 2015, graduate programming in integrative medicine was developed to train practicing clinicians to adopt the integrative approach to patient-centered care. Then in 2018, under the Department of Clinical Research and Leadership, the Office of Integrative Medicine and Health was founded, which soon launched the GW Integrative Medicine podcast, which you can listen to anywhere you get your podcast or on our website. Then, most recently, in 2019, the Integrative Medicine Nutrition programs were launched. Integrative medicine at GW has a long and strong tradition of leading the way in this cutting-edge field, including this annual symposium. All previous symposia are freely available on our website, including last year's on the gut microbes and well-being. To kick off this year's symposium, we are fortunate to have Barbara L. Bass, MD, Resident 86, Vice President for Health Affairs, Dean of the GW School of Medicine and Health Sciences, and Chief Executive Officer of the GW Medical Faculty Associates, a widely respected leader in academic medicine, a surgeon, and a published author known for her pioneering innovation in academic surgery. Thank you so much for joining us to give the opening remarks, Dean Bass. I'll turn it over to you.
Thank you so much, Dr. Frame. It's great to be here and for the 7th annual Sung Symposium, really an accomplishment. And I think it's really exciting that GW has hosted this wonderful event for such a long time. I know that this one happens to be about sleep, something that I think I hold very dear to heart, and I hope everyone does, because it is one way we know, which is so vital to one's health. Although oftentimes we have things that interfere with that. So I'm really curious about and looking forward to this important symposium. For those who don't know, the Sung Symposium is really was established to promote wider awareness and dissemination of integrative medicine practices, as well as to advance the field. And today you're going to hear about some of the wonderful research that's ongoing here at George Washington University, as well as noted authorities from around the nation, around the nation, who will contribute as collaborators as well in this important work. This program was founded by a very most generous gift from a GW alumnus, and that is Patrick Sung, a graduate of the law school, as well as a PhD graduate. And generosity has what has enabled both this strong program in integrative medicine, but especially the symposium here. And we're forever grateful to the Sung family for that gift. I want to note that this year here at GW is important in that it is actually our bicentennial year. Our GW School of Medicine and Health Sciences, at least the medicine part, and the health science part isn't that far behind, is 200 years old. And as a university that was founded by an act of Congress in honor of George Washington, we are very proud that medicine was one of the core disciplines that was recognized as a mission that this university would support. As we celebrate our bicentennial this year, we have a number of highly attractive and interesting programs that we're putting on, both for our research and academic community, for our students, but also for our public-facing side of the house, to let the world know about the exciting work that's going on here at GW across all of our missions: education, research, and clinical care. Whereas an academic medical center, we contribute to all of those. So I hope you'll keep an eye out for these bicentennial events and enjoy them. And I really thank the Department of Integrative Medicine for having shared this symposium as part of that year-long celebration. I won't say too much about the importance of sleep. I think we're going to hear all about that from our authorities today. but it is one where we at GW have some real depth in our research and educational initiatives. And today we'll hear some of that work from some of our notable scientists, but it's built on our clinical experience in terms of our sleep center and the research that goes on there. It's based on the educational training programs we have in integrative medicine and integrative health and whole health medicine that really have been an area of focus, as you pointed out, Dr. Frame, for many years here at GW. We're sort of early on to that bandwagon, I'm going to say, that adoption of expanding the tools of modern medicine from that historical allopathic genre to include those known measures, which we constantly evaluate and improve, that really can contribute to not just treatment of disease, but enhancement of health, that whole health concept. Very exciting program here at GW. In terms of our particular speakers that we're going to hear today, we're particularly proud to have some that have joined us recently with, as well as longer standing faculty members who have real expertise in the science of sleep and disordered sleep, including all of our speakers. But I'll just name the four that I know will be presenting in this symposium. Dr. Vivek Jain, we're delighted to have you here. Dr. Polotsky, who joined GW about a year ago and really has a remarkable basic science research program in sleep medicine. Dr. Lauren Hablitz, thank you for joining us. And Dr. Liza Ashbrook. We're delighted to have this distinguished panel to share their expertise with us today, and I really look forward to that. But I want to wish everyone on this symposium a great learning experience, one that I hope will foster your evolution as a whole health researcher, investigator, physician, practitioner, and I really thank you, Dr. Frame, for having put this magnificent program together.
Thank you very much, Dean Bass. So we are really thrilled to have you here, especially being the bicentennial year. And I also want to extend thank you to all of our speakers. We obviously cannot do this without you. And thanks again to the Sungs who made this all possible 7 years ago. We have a lot of thanks and gratitude for all of you. And today, the work of the Office of Integrative Medicine and Health is made possible by generous donations just like the ones from the Suns, from people who've been touched by integrative medicine around the globe. And we hope you too will consider supporting our work, such as this free annual event. With that, I will turn it over to the Medical Director of the GW Center for Integrative Medicine, Dr. Mikhail Kogan.
Thank you, Dr. Frame, Dean Bass. Thank you so much for the wonderful introduction. So I get a pleasure to introduce our first speaker, somebody I know personally really well. I was just trying to figure out, at least 15 years we've been cross-referring patients. Pulmonologist Vivek Jain, MD, is a leader in sleep medicine research, associate professor of medicine here at the Division of Pulmonary Critical Care and Sleep Medicine at GW. He also serves as a director of the GW Center for Sleep Disorders, a position he has held since 2009. So Dr. Jain has been on campus for a long time. Dr. Jain obtained his medical degree from the All India Institute of Medical Sciences in New Delhi, India, and he did his internship at the Rush University Medical Center. He did his residency in internal medicine and fellowship in pulmonary and critical care medicine at the University of Missouri Hospital Clinic in Columbia, Missouri. Dr. Jain's research on various aspects of sleep disorders have been published in more than 50 peer-reviewed scholarly journals and numerous books. I do personally want to highlight that had a whole chapter on the effects of music on sleep. I find that totally fascinating, and it tells you a breadth of our colleagues. They're not just looking at the sleep from, more purely medical perspective, but as you hear from speakers, this is a lot broader, more holistic way of thinking and looking at it. He's been named one of the Washington top doctor 6 times since 2012. And as I mentioned, we shared multiple patients together. Dr. Jain has been training physicians and PA students and interns and residents and fellows for nearly 2 decades. And so with that, I'll pass it on to him to present to us the sleep to support whole person well-being. Thank you, Dr. Jain, for joining us today.
All right. Thank you, Misha, and thank you, Dr. Frame and Dr. Bass. Let me share my screen here. I hope everybody can see that. Good. Well, thank you again for the organizers for this. Obviously I'm biased towards sleep, so a well thought of symposium and a good topic for this symposium on sleep. Let me see if I can advance the slides. I'm going to start with this Irish proverb: a good laugh and long sleep are the best cure in a doctor's book. Unfortunately, poor sleep health in the United States is an epidemic. If you look at the numbers, and these are outdated probably, these are probably a decade old, and things have probably gotten worse since then. But 50 to 70 million Americans complain of being or suffering from some form of a sleep disorder. And if you just look at the numbers on sleep deprivation, if the optimal amount of sleep that we need is 7 to 8 hours, 1 out of every 3 Americans complains of having less than 7 hours of sleep. Not complains of it, that's what they get. They get used to it, but obviously we'll talk about how it has an effect on our overall health. 10 to 15%, probably again a very small or underestimated number that comes to the clinic complaining of a sleep disorder. Shift work, it's a separate topic, and I'm sure one of our speakers who, on circadian rhythms will perhaps touch on this topic. But 20%, if perhaps not more, of our workforce is doing some form of shift work, which it can have an effect on the quality of sleep. If you look at these numbers from the NHANES data here in the lower right bottom, you can see clearly that number of people complaining of having less than 7 hours of sleep is, probably in the range of 25 to 35%. And then when we see people in the sleep clinic, and this is what we train our fellows and residents to recognize, that people will not just have one sleep complaint or two sleep complaints. Even 10 to 15% of the patients coming to the clinic will have more than 3 separate sleep disorders that they'll be complaining of. So, we can't just say it's sleep apnea or sleep deprivation or insomnia. They may have all these things in combination. Now, poor sleep health can be due to many, many different reasons, but I'm just going to try and focus on insufficient amount of sleep. That is probably the most common reason for why people feel sleepy and tired in the United States. And it's probably most under-recognized even in clinics. And throughout most of my talk, I'll be talking about the effect of sleep deprivation on our health. There will be a speaker later on today who will be talking about how timing of sleep and its desynchrony with our requirement or our physiology can cause sleep disorders, circadian misalignment. And then obviously there's a whole plethora of different kinds of sleep disorders that can cause poor quality sleep or poor sleep health. We'll have a talk on sleep apnea. We won't be touching on narcolepsy, restless legs, or insomnia. The latest ICSD classification on sleep disorders talks about 105 different sleep disorders, and obviously we won't have time to touch on all those. We all familiar with the consequences of poor sleep health. We look at these as items in a newspaper or on the websites, and then we just ignore them and we say, hey, let's carry on. But all of these have been linked in one way or the other to either sleep deprivation or sleep apnea or some form of sleep disorder. So my objective today would be to talk about what is normal sleep, what is the normal sleep duration that we should aim for, what have you learned over the years about what is the function of sleep. I mean, sleep is ubiquitous. I mean, every living being has what we call as a sleep rest or rest activity cycle. And what have you learned over the last 30, 40 years about what is the actual basic function of sleep, and what are the causes and consequences of poor sleep health? All of us, I'm sure, know about this, at least in this audience, that sleep is 2 types: non-REM, which is non-rapid eye movement sleep, and the rapid eye movement sleep. And we've recognized over the years that the non-rapid eye movement sleep can be further divided into what we call as non-REM 1, 2, and 3. Non-REM 1 may or may not even exist in a given person. Most of our sleep is NR2 or light sleep, and then we have something called the deep sleep or NR3 sleep. There used to be a fourth stage 4 sleep or NR4 sleep that we've stopped using in classification of sleep because it's difficult to score NR3 versus NR4. The first sleep that was recognized before we had EEGs and fancy electrodes and stuff like that was the rapid eye movement sleep, because it was so obvious to people looking at, just when you look at somebody sleeping, they'll have these phases where they'll move their eyes rapidly. Um, in our sleep labs, when we recognize these different stages of sleep, we base it on basically how the EEG looks, in addition to other things that are happening, including eye movements and what is happening to the muscle tone. Here you can see that deep sleep has these big EEG waves, which are slow and tombstone looking with high amplitude. So that's the definition of really deep sleep. What's also fascinating to us is that when you look at these EEG during REM sleep here at the bottom, and we compare that to what maybe light sleep or even wakefulness, they look very similar to each other. And that's why sometimes REM sleep is also known as paradoxical sleep, because from an EEG perspective, it looks very similar to what awake looks or even light sleep looks, but obviously the person is sleeping. Not only do we have these different stages of sleep, but throughout a given night, we go through these stages in a kind of a well-defined manner. And we call that a hypnogram, so just a tracing of the different stages of sleep throughout the night. So here on the x-axis, you have the hours of sleep as you start from, going to sleep and then throughout the night. And most of us will go into sleep by starting into either stage 1 or stage 2. And then we go into our deeper stages of sleep. Then we come out of those deeper stages of sleep to go into a light stage of sleep before we go into our first REM sleep. And REM sleep is usually, and by convention, represented by these bars. And what you can see is that in any given night for a normal individual, the first half of the night is where we have predominantly deep sleep and slow wave sleep. And for years and years and years, we used to call that the requisite sleep. So if I can sleep the first 4 to 5 hours, we'll call that the requisite sleep, because we get most of our deep sleep at that time. And pre-industrialized societies could even have the concept of something called 2 sleeps, that we would sleep 4 or 5 hours, wake up, and then go back to sleep again. Second half of the sleep is where we have most of our REM sleep. So we have these sleep cycles that cycle every 60 to 90 minutes. But during the first few stages or cycles of this sleep, we'll have most of our deep sleep. And towards the end, we may actually stop having any deep sleep at all, but we have most of our REM sleep towards the end. Now, one thing, before I go into what are the different, is there any difference between REM and non-REM, but in terms of function, but most of our sleep, like I said, is going to be stage 2 sleep. And the way I remember it, and I teach it, is that half the sleep is stage 2 sleep or light sleep, and the other half is equally divided between deep sleep and REM sleep. So 25% of deep sleep and REM sleep, and 50% is stage 2 sleep. In spite of years and years and years of research, when we talk about sleep deprivation, it's rare to talk about just non-REM deprivation or REM deprivation, because it's not known yet what are the actual functions of each stage of sleep. Because even in normal people, there could be complete absence of slow wave sleep or deep sleep, and they're functional people. Some studies have shown that by the time we are 20 years of age, maybe 5 or 8% of us will have no deep sleep, but these are normally functioning people. Same thing with REM sleep. Things like antidepressant use completely eliminates REM sleep. And yet there's absolutely no negative effect of the absence of REM sleep. Certain disorders like depression have a lot of REM sleep. We don't understand why. So again, when we talk about, in my rest of the slides, about sleep deprivation, rarely do we talk about like non-REM versus REM deprivation. We talk about total sleep deprivation. We do know that our sleep changes in quality as we age. So as in a young adult, we'll have this beautiful, nice looking hypnogram where we go through these kind of stages of sleep that we described. But if I was to do a hypnogram in somebody who's 70, 75 or plus years of age, this is quite typical that we'll see a lot of what we call a sleep fragmentation. We'll see less amount of deep sleep. We'll see even the REM sleep, though it happens every 60 to 90 minutes, each episode has less REM sleep. And there's lots of awakenings throughout the night. And these are normal, otherwise healthy, elderly people. And yet they have this abnormal sleep architecture without a significant consequence. Now, certainly as we get older, is it a neurological reason why we have this kind of sleep disruption or abnormal sleep architecture? Is it due to comorbid conditions? Is it due to medications? And that's something that can be argued. So in general, what we see with aging is that the amount of time it takes to fall asleep does not change. The amount of REM sleep doesn't change significantly until really late in life. What changes very quickly by the time we are 20, 30, 40 years of age is that the amount of deep sleep starts decreasing. What also changes very rapidly is that the number of awakenings of what we call as wake after sleep onset increases as we get older. So we have more of these awakenings throughout the night. Obviously, the amount of light sleep remains pretty constant as we age. The other thing that I want to introduce as a kind of a general concept of physiology of sleep is what controls sleep. Why do we sleep? When do we sleep? How much do we sleep? Is governed by basically two processes, and we call that the homeostatic process, or the process S, and the circadian process, or process C. And as you can see here on this graph, is that as we are, so here you are, this is the homeostatic sleep drive, and as we start our day, we get up in the morning, and as we continue throughout the day, the homeostatic drive to sleep increases. So we have this pressure to sleep increase as we go through our day, and that's why it allows us to sleep when the night comes. But on the other hand, to counteract that drive to sleep throughout the day, we have a circadian drive that allows us to remain awake. And so that increases. So the circadian drive is a wakefulness drive, and that is increasing throughout the day. Let me see where my arrow is right here. So you can see this go up. So it counteracts that pressure that I'm building to sleep. Now, is somewhere in the afternoons, right about now, in most of us, we'll see that there's going to be a brief moment in time where the circadian wakefulness drive will be slightly less than the homeostatic sleep drive. So we have this, what we call as an afternoon dip. And so it's normal for us to feel a little drowsy and sleepy sometime between 12 noon and 4 p.m. But unfortunately, as societies, we've decided not to encourage taking naps, though I think in sleep societies, that concept is changing, where we are telling our patients and our colleagues to not be shy about taking a 15, 20-minute nap in the afternoon, because that has been shown to increase productivity and also actually have a cardioprotective effect. So that could be a whole separate topic, and like to nap or not to nap. But I think physiologically, we all have a tendency to nap. So if any of you is falling asleep at this time during the seminar, it's not because of the boringness of the topic, but it's a normal circadian dip that's happening in the afternoon between 1 p.m. and 4 p.m. So people, again, sleep, as I said, is a conserved phenomenon. Evolutionary. Every living species, plants, animals, have what we call as a rest activity cycle. And so the question to scientists has been, what is the function of sleep? Again, these are based on some scientific data. But again, it's still, the full function of sleep may not be completely still apparent. But in general, sleep, there are neurons which are active during sleep. So it's not like a totally passive state that our brain is just completely not having any neuronal activity. But the areas of the brain that are active during sleep are the ones that are conserving energy in general. And the ones that are active during wakefulness are the ones that are spending that energy. So it's more like during sleep, we conserve our energy. So, things that are going to be active during sleep are going to be things that are, like things like growth hormone or prolactin or luteinizing hormone, testosterone, things that are allowing us to hold on to energy, as opposed to things during the daytime, things like norepinephrine, which is going to be highly, the wake promoting neurons are going to be active during wakefulness, things that are required for things like vigilance, food seeking, seeking a partner, foraging, or things that are required for temperature regulation. So during, wakefulness, we know that the body temperature is higher as opposed to during sleep when the body temperature falls. things like immune function, and we'll talk about that. That is, sleep is very important to restore immune function and immunity for the body. Reorganization of the neural network, something called synaptic pruning, repair work that goes on inside the body for things that have been damaged, oxidized during the day at the cell level. And so we need, different phases in our 24-hour period where we can do certain things in different compartments and silos. Um, Here's an experiment that was done looking at sleep deprivation experiment, not in humans. This is in rodents. We don't do these kind of experiments in humans where we sleep deprive an individual for up to 6 days continuously, total sleep deprivation. And as you can see in this animal model, because I'm not sleeping, I'm obviously spending energy without conserving energy. So I will lose body mass, as you can see over here. And then, in spite of the fact that when I'm awake, I'm going to be eating a lot. So these mice are constantly eating and yet losing weight because energy balance has changed because of lack of sleep. But after about 6 nights or 6 days, 24-hour periods of continuous sleep deprivation, they will start once again gaining weight, even though their food intake really goes down. So it's the opposite. They just give up. And then, usually after about 2 weeks, these mice of complete sleep deprivation, they die. So we don't do these experiments in humans. We will have a talk about this later on with Dr. Hablitz talking about, is sleep important for something called metabolite clearance? So our neuronal activity is going on during the day, we are accumulating toxins in the brain. And so we need some time in a 24-hour period to clear those toxins from the brain and the CSF. And so this is experiments done again in rodents, looking at the clearance of beta amyloid protein, as you can see in these orange triangles where the rodent is kept awake, as opposed to in sleep conditions or conditions under anesthesia. The clearance of the beta amyloid from the brain is much more during sleep than during wakefulness. And same thing, we can inject something called a carbon-labeled inulin into the frontal cortex of these rodents, and we can see that the clearance of that metabolite is going to be faster during sleep. And so, Dr. Hablitz will be talking more about why this clearance of these toxins and beta amyloids is important, because if these things accumulate in the brain, they are part of the reason why we develop things like neurodegenerative diseases and dementia and things like that. And there's a whole, again, whole literature looking at, causes of, or links between sleep issues and cognitive issues, including, risks for dementia. Here in humans, people have also looked at, changes in sleep efficiency here on the right side, where I'm again finding my arrow here. So if my sleep efficiency decreases, that means I'm experimentally disrupting the sleep of these young volunteers. So these are people who are otherwise healthy, and I'm just experimenting on them by disrupting the sleep. I can see that something called tau, which is another bad protein in the brain, will accumulate with worsening sleep efficiency. Again, tau is a bad thing to accumulate in the brain, causing neurodegenerative changes. One thing that's obviously been studied now for 20 years is the association between good sleep and memory consolidation. And the memory consolidation that's been looked at could be declarative memory, could be procedural memory, could be emotional memory. And it is well now recognized that sleep will strengthen the memory both quantitatively and qualitatively. That means during sleep, and I'll show you some examples, that we actually enhance or strengthen associations of that memory with other experiences that we've had in our life, and therefore we are in a better position to make conclusions and inferences, especially during recall. So what happens if we have an experience during wakefulness, such as listening to this talk? We do recognize here in blue is the hippocampus in this cartoon, and then there are projections that go to the neocortex. So most of our experiences are first going to be, experienced or kind of having a synaptic connection at the level of the hippocampus, and from there those experiences are relayed through a neuronal network to the neocortex. Now, when we go to sleep here on the right-hand side, even though we're not actively engaging the hippocampus anymore because the experience happened during the daytime, but the neocortex is replaying those experiences and both making new synapses, pruning some of the synapses, causing more associations based on the experience that we had during the daytime. So sleep is actively reprocessing things that happened during the daytime. Now, this is again an experiment done in mice where you can see that how the you do measurement of neural activity, say at the level of the cortex or the hippocampus, and you can see that when the mouse was running, and I was able to measure the signal coming in from the cortex and the hippocampus, there are certain activations going on during the time when the animal is running in both in the hippocampus and the neocortex. But when the animal goes to sleep, you can see some of this replay still happening, both in the hippocampus and the neocortex. So that means the brain is still kind of reprocessing some of that information that was acquired during wakefulness. Similar things in humans, and so this is what we call as a computer-based model where the subject is going to recognize what we call as object recognition task. So they have to know, like, which of these cards is going to be a tree, say, for example, or a flower or something like that. And while the human is doing this task, they're also being exposed to a certain odor. Okay. Now, the human has stopped doing this task, and I want to retest how they recall where those certain objects were the next day after they've slept. And I expose them to the odor while they were sleeping to see if that has an effect on their memory or the ability to recall that task. So this is what this experiment is doing. And the fascinating thing is that while the subject is sleeping, I expose them to the odor while they're in slow wave sleep or deep sleep, the recall is much more the next day. If I expose the individual to an odor during the time when they were in REM sleep, the recall is much less. If I expose them to the odor the next day during wakefulness, or they were not allowed to sleep throughout the night but were exposed to the odor, obviously the recall is much less. So there is this kind of a, activity in the brain that is happening during night, which is causing associations, and perhaps the task recognition was associated with the odor, but was enhanced during slow wave sleep. What has also been shown is, so hippocampus is important for memory processing or memory consolidation or memory recognition or memory recall. And so people have looked at effects of sleep deprivation on just hippocampal volume, and the hypothesis is that if the hippocampus is being affected, then our ability to remember things is going to be less. So here's data from children who were sleep deprived and looked at the hippocampal volume, and you can see that the more sleep deprived the child is, the lower is the hippocampal volume after a follow-up period of 5 to 7 years, roughly. Similar data is coming from insomnia studies, which we are not talking about today, which itself is a separate sleep issue. But one can see that both, here's the data from both the right hippocampal volume and the left hippocampal volume. And this is the duration of insomnia in years on the x-axis. So the longer I have had insomnia, I'm more likely to have a loss of hippocampal neurons. Again, suggesting that perhaps poor sleep health will affect memory. And it does, same thing with something called the arousal index. So arousal is just like a polysomnographic measurement of how my sleep continuity is. So more arousals in the brain is a kind of a sign of loss of sleep continuity. So more arousals there are, lower is the hippocampal volume. And so idea is that poor sleep health can cause memory problems, perhaps because of the loss of hippocampal volume. So just a kind of a cartoon to summarize this in a human, that during wakefulness we have sensory input coming in through through different organs. So there's an event, there's a context, we encode that. Initial storage of that event takes place on the hippocampus. During the night, we consolidate that memory by replaying it in the neocortex, and then if we need to, many years down the road, recall that event and form of an association, we have that capability because that memory has been formed. What I wanted to show you with this schemata is that we have a similar thing that exists in our immune system, where when our immune system similarly has a capability of remembering. So that's why when I'm exposed to a certain foreign body or an antigen, and the antigen processing cell or the lymphoid tissue uh, creates and like an antibody or a T cell that to fight that antigen of the foreign body. So it does that immediate response. It recognizes an event, which in this case is the antigen, but then it creates a storage of that memory of that bad antigen for years down the road. So when I'm re-exposed to that antigen, I will be able to mount my defenses again. So that's what is acquired immunity, is essentially that I can recall that event many months, years down the road and respond to it. And that's, purpose of vaccines. So one of the interesting things that we've recognized in sleep and immunity is that if I was to take an individual who is who's been given a flu vaccine or a hepatitis vaccine or a COVID vaccine, and I allow that individual to sleep, my antibody response to that vaccine is going to be much more robust as opposed to an individual who's had insufficient sleep on the night after the injection of the vaccine. And that is why, at least, I tell all the patients that if you're going to get a flu shot this season, or please make sure that you get enough sleep after getting that vaccine, because that will help you mount a much better, a much more robust antibody response to the vaccination. And this kind of paradigm has been reproduced in many other scenarios, where it could be a sleep restriction paradigm, it could be an insomnia paradigm, it could be shift work, where we've recognized whether it's an influenza vaccine or hepatitis A vaccine, B vaccine, meningitis vaccine, the response is much worse if I have poor sleep health. Now, the only study that I came across that was done in people with looking at COVID vaccine is if they had underlying sleep apnea. And the study was just specifically looking and seeing if I have a good antibody response or not, and they did not find any change whether I had sleep apnea or I did not have any sleep apnea. But they did not do the study specifically for insomnia, shift work, or sleep deprivation. In general, as a summary, if I'm sleep deprived, I do bad things. I have an uptick of things like the inflammatory mediators. So sleep deprivation changes my balance more towards inflammation as opposed to anti-inflammation. So inflammation is bad for the body. A lot of the inflammatory markers go up, which then can lead to things like cardiovascular disease, infection risk, neurodegeneration. My ability to produce antibodies goes down. My ability to present the antigen to the antigen presenting cell goes down if I'm sleep deprived. My innate immunity, which is dependent on natural killer cells and something called the Th1, Th2 response, is going to be affected if I'm sleep deprived. So sleep is good for immunity as well, besides memory, besides energy conservation. Now, what is normal sleep duration? So again, a separate, area of research that's been conducted over the years, looking at the amount of sleep that we need at different stages of our life. Most newborn babies need about 12 to 15 hours of sleep. As we get older and become teenagers, adolescent years, we require maybe 9 to 10 hours. Adults require 6 to 8 hours, which is well known. I haven't put up a slide for this, but people recently conducted a whole series of experiments in so-called the non-industrialized societies. Like, these are primitive tribes that are living without electricity, without modern day amenities, out in Africa and Central America, and found that even in those communities, adults are sleeping 6.5 to 8 hours. So that's considered to be our so-called sleep needs. As I mentioned, a third of the population sleeps less than 7 to 8 hours, and this is both for men and women, and that's a real problem. So here you can see on the left side of this slide that there are a substantial number of both men and women who are getting less than this 7 hours of sleep. there are people on the other hand and also who are getting more, but this is the part that we are really worried about. The amount of sleep that we've started obtaining has decreased over the last 2-3 decades. So, here's both in men and in women. So men being shown in this red, women being shown in blue. In different ages, we used to get more sleep back in the 80s. Now in the 21st century, we are on average getting 30 to 60 minutes less sleep in across all age groups and in both genders. And that's a real problem. Uh, for some reason, again, it's blacks tend to get less sleep as opposed to whites and Hispanics. Uh, Again, is it a cultural thing? Is it the fact that more blacks do shift work, more have long commute times? Again, that's another separate area. But in general, African Americans are getting less sleep opposed to other races. This is an interesting fact that we also have a geographical distribution of sleep duration. So, people have looked at this and found whereas, people on the East Coast tend to have less sleep as opposed to people on the West Coast, and and uh, and I guess it is hypothesized that part of the reason is that a late night show, obviously starts at a later time on the East Coast as opposed to the West Coast. You know, uh, Stephen Colbert or whatever, Trevor Noah or whatever. So the start times are there. So people have looked at bedtimes. So the bedtimes are much later on the East Coast as opposed to the West Coast, perhaps because of this reason. And maybe that's the reason why we have less sleep or more sleep deprived individuals on the East Coast as opposed to the West Coast. Now, sleep deprivation can be acute or partial. So, I need 8 hours of sleep. Tonight I go home, I sleep only 4 hours because I'm out with friends, but I make up for that lost sleep the next day. So there's this so-called the acute sleep deprivation paradigm. But I think the more real, common thing that exists in the society is what we call as chronic partial sleep deprivation. So it's that we have repeated failure to obtain sufficient amount of sleep to recover from the sleep lost during the previous night or the previous 2 nights. David Dinges from UPenn had done, the study 20, 30 years ago, which I still tell patients is that if I lose a certain amount of sleep tonight, I have to make up for that lost sleep in the next 48 hours to fully recover. Now, in real life, what most of us do is we try to recover that sleep on the weekends. So after 3-4 nights of sleep deprivation, we try to recover on the weekends. And what's been clearly shown that that's never, never, never going to be enough. So we have to do it within the first 24 to 48 hours of losing our sleep. Otherwise, there's going to be this detrimental effect of constantly linearly losing sleep as time goes by. So here's studies done in humans looking at something called a vigilant psychomotor vigilant task, and where we are giving instructions to the subject and saying, hey, do if I say one, click. If I say two, don't click. Odd numbers, even, or whatever we have, and we're looking at how many times are they able to respond to the task in question. And here at baseline, again, where's my arrow? Let me get that onto the screen. Here we are. So here we are, as time goes by, this is an experiment done over a 2-week period. And while the subject is being allowed to get adequate amounts of sleep, they continue performing pretty well. But then during this 2-week period, I allow them only 6 hours of sleep during the night, you can see that the number of lapses go up. And then if I similarly do only 4 hours of sleep at night, the number of lapses go up even more. And of course, if a complete sleep loss, there's going to be just, they give up after the first 2 nights of sleep deprivation. Similarly, you can see the graph for my subjective sleepiness scale score. If I am sleep satiated, I have no problems, feeling good throughout the 2-week period. But then I start really noticing a problem as time goes by. Now, this is interesting. And this is something that I do tell patients that, as you can see over here, that after the first 2 nights of sleep deprivation, of 6 hours of sleep at night, I subjectively feel sleepy. I report feeling sleepy during the daytime, but it plateaus off as my sleep deprivation goes on. And that is a problem, because when people are chronic partially sleep deprived, they stop recognizing that they are sleepy in the daytime compared to normal, healthy individuals who are getting adequate amounts of sleep at night. And that's the reason why they don't come to us. They feel fine, in quotes. Now, when we look at this, sleep duration and its effect on health, one can look at it in many different ways. And one of the ways in which people have looked at associations between sleep duration at baseline and things like all-cause mortality as time goes by, one can see this nice U-shaped curve. So here in the middle, where I'm getting 7 to 8 hours of sleep, I have the lowest hazard ratio for dying on all-cause mortality in both men and women. But if I'm getting less than 7 hours of sleep, that hazard ratio goes up. But what is also surprising is that if I'm getting more sleep, then also the hazard ratio goes. Now, this has remained a real mystery to us, that when people are so-called long sleepers, why do they have this issue of having higher mortality compared to people who are sleeping the adequate amount, 7 to 8 hours, or the optimal amounts? People have tried restricting the sleep in these individuals, but they did not have any change in outcomes. Getting more sleep to this individual definitely has a change in the outcomes. Now, similar U-shaped curve exists for other outcomes as well. So if one looks at the relationship between sleep duration and, say, prevalence of hypertension, again, a nice U-shaped curve. If I'm sleep deprived or I'm getting too much sleep, my chances of developing hypertension go up. Again, model 1, model 2, model 3 looks at confounding variables. So you eliminate all the other variables that could be causing risk for hypertension, and even after eliminating those variables, the risk for developing hypertension is associated with sleep duration. Similar, body mass index. Optimal sleep allows me to remain thin, but if I have less sleep, I gain weight. If I have more sleep, I gain weight. Similar relationship between development of diabetes and impaired glucose tolerance. So many outcomes have shown this kind of a U-shaped curve. So why is this U-shaped curve prevalent? So I'm going to focus on what could be the reasons why, when people are sleep deprived, they develop this risk for developing hypertension and all-cause mortality or cardiovascular disease risk. So people have looked at things like endothelial dysfunction or autonomic balance, which as most cardiologists will tell us, are the reasons why there is an increased risk for cardiovascular disease. So if there's endothelial dysfunction, I'm going to develop a higher risk for cardiovascular disease. Autonomic balance, meaning sympathovagal balance. So if the sympathovagal balance is more in the favor of the sympathetic nervous system as opposed to the vagal nervous system, then I'm going to be at a higher risk for developing cardiovascular disease. So if I take two sets of individuals, those who are sleep deprived versus sleep satiated, 7 hours being the cutoff point, and I follow them over a period of time, in this particular case, 15 to 20 years, and I recheck their brachial artery diameter. So the higher the diameter, the worse the outcomes. And I also look at something called flow-mediated dilatation, which is a very common way of looking at something called vasoresponsiveness. So if I occlude the brachial artery and I then, because of ischemia, I should have the ability to dilate my distal vascular beds. And if I release the cuff from a brachial artery, I want to see how much I dilate. And if I don't dilate, that's a problem. So the flow-mediated dilatation decreases with sleep deprivation, and the brachial artery diameter increases with sleep deprivation, both being bad things for cardiovascular outcomes and suggesting endothelial dysfunction. Similarly, if I look at something called the vaso or sympathovagal balance, so we use something called heart rate variability to measure that. What we look at, heart rate variability in the frequency domain. And if I am predominantly in the low frequency domain, that's a bad thing. If I'm in the high frequency domain, that's a good thing. So here you can see that with sleep deprivation, so here's a control set of individuals who are getting good, adequate amounts of sleep versus those who are sleep deprived, getting less than 7 hours of sleep. And the low frequency domain goes up as a percentage with sleep deprivation, and high frequency percentage goes down with sleep deprivation. So the LF to HF ratio goes up, which is a bad thing, suggesting that my sympathovagal balance has changed. Similarly, I can also look at vasoresponsiveness in response to acetylcholine. If I inject acetylcholine, my vasculature should dilate, and which is a good healthy thing. And with sleep deprivation, my ability to dilate the vessels in response to the ACH goes down, which is again a bad thing. The other thing that we've recognized as an association with sleep deprivation is the risk for obesity. In fact, there was an editorial several years ago calling it the tale of two epidemics in the United States, that as we have become a more sleep deprived society, we have also become a more obese society, and perhaps the two things are linked. And as the association between sleep deprivation and obesity, just because by being awake we have an increased opportunity to eat, are we just more tired and therefore we have reduced energy expenditure? Is there an alteration of the thermoregulation causing less energy expenditure? Or are we just more hungry? And so we have focused on this thing about increased hunger, because we've recognized even amongst ourselves that when we are fatigued, we reach out for bad food. So we want that sugar rush. We use eating as an antidote to fatigue and sleepiness. And we know that things like leptin and ghrelin are controlling our satiety and hunger. And so people have looked at the association between sleep deprivation and leptin levels and renin levels. And this was data from University of Chicago, Karen Spiegel, Eva Van Cotter from many years ago, looked at, if I'm sleep deprived, my leptin levels are going to be lower and my renin levels are going to be higher. And leptin, being a hormone of satiety, tells my brain that I don't need to eat, but if my leptin levels are going to be low, I'm going to constantly feel hungry. And renin is something that stimulates the appetite. So if my renin levels are high, I am going to subjectively feel more hungry. And so they show this clearly that in that same individual, my ratings of hunger were higher if I was sleep deprived, and ratings of overall appetite were higher if I was sleep deprived. The other thing is to look at the association between sleep deprivation and glucose intolerance. One can look at this in acute sleep deprivation, and one can also look at it at a population level and see if there's an association with chronic sleep deprivation. So this was an experiment done in otherwise absolutely healthy young individuals who had no sleep complaints, who had no metabolic complaints. They had normal blood work at baseline. They were 18 to 27 years of age. And they were put through the sleep restriction paradigm, where at baseline, they slept their 8 hours per night. And then for the next 6 nights, they were sleep deprived and were made to get only 4 hours of sleep at night. And then they were allowed to recover from that sleep deprivation by being allowed to sleep 8 to 12 hours for the next 6 nights. And then they looked at what happened to my glucose tolerance, my insulin clearance at each point in time. And what was shown was that if during the time when I'm sleep deprived, my ability to clear the glucose after intravenous glucose or after breakfast is much lower, as opposed to people who are sleep satiated or during sleep recovery. And the idea is that if I eat something or I'm given a glucose load and I don't clear it, my tissues are going to be exposed to that glucose level for longer periods of time, which is a bad thing. Same thing, my insulin response is going to be lower to that same glucose load, and which is again a bad thing, because insulin should helps clear the glucose from the blood. And if my insulin levels are going to be lower because I'm sleep deprived, that's not a good thing. So the idea really behind this acute sleep deprivation model was that even otherwise healthy individuals, if sleep deprived for 5 nights or 6 nights, become diabetic, essentially. Of course, luckily they recovered back to their baseline after being given the opportunity to sleep ad lib. Now, in the same individuals, they also looked at, obviously levels of sleepiness, sympathovagal balance, and evening cortisol, and found that, not surprisingly, that their levels of sleepiness were much higher. Like I mentioned, the sympathovagal balance shifted towards the sympathetic system because of sleep deprivation, and evening cortisol was higher. So that's a bad thing, because cortisol normally is the highest when we first wake up in the morning. The way I teach is that waking up is stressful. That's when I get my cortisol up. It should not be high in the evenings, but in these people, it is high in the evenings, which is not a healthy thing. Again, that's an acute sleep deprivation model. That's not real life. The real life model is chronic sleep deprivation, because that's what most of us suffer from, where we never give ourselves the chance to recover from our sleep debt. So this was a nurses' health study that had been conducted back in the 70s and 80s. So they started the study in the 70s, looking at the nurses and their outcomes on things like cardiovascular health. They were not really collecting numbers about sleep at that time, and I think sleep became more fashionable in the late 80s, early 90s, and so they started collecting sleep-related data only in the 1980s, and looked at sleep duration as one variable. And they followed these, in their pool, they had about 70,000 nurses from which they had the data regarding sleep, and they followed these women for a decade and looked at incident diabetes or glucose intolerance that developed over time. And what they found was, over a 10-year follow-up period, if I looked at the correlation between or association between baseline sleep deprivation and the risk for developing total diabetes and symptomatic diabetes, the odds for developing those two conditions was higher if I was sleep deprived, if I was getting less than 7 hours of sleep, or again, more than 8 hours of sleep. So again, the magic number for how much sleep we need seems to hang around this 7 to 8 hour mark. So I'm going to end my talk by saying, with poor sleep health, is this the kind of future that we're going to be looking at? And so my parting thoughts would be, to all of us in the audience, to people in general, all the patients who come to the clinic, let's all focus on good sleep health. So let's focus on getting the right amount of sleep, the right timing of sleep. If you have a sleep disorder, whether it be insomnia, apnea, narcolepsy, restless legs, let's take care of those. Thank you.
Oh, thank you so much. That was the perfect opening. You really set the scene for people understanding why sleep is so important. And we all recognize it as important. Hopefully all of you now also recognize that sleep is incredibly important for our whole health. Our next speaker, Dr. Vsevolod Polotsky, is professor in the departments of anesthesiology and critical care medicine, pharmacology and physiology, as well as medicine, here at the GW School of Medicine and Health Sciences. He's vice chair for research in the Department of Anesthesiology and Critical Care Medicine, where he's implementing a vision for neuroscience, pharmacology, and physiology and pain research. Before coming to GW, Dr. Polotsky was a professor of medicine at the Johns Hopkins University School of Medicine, which is where we first met back in 2006 when I joined the team of a study for which he was a co-PI. And I can tell you that Dr. Polotsky, or Seva as I would call him, is a brilliant scientist and a very kind person. I'm thrilled he's now here with us at GW. Dr. Polotsky is an internationally known clinician scientist with expertise in neuroscience and a focus on sleep medicine. He is a world-renowned expert in animal models of obstructive sleep apnea and metabolic complications of sleep apnea. His research interests include hypoxia, obesity, and metabolic syndrome, while currently researching chemogenetic manipulation of the innervation of upper airway musculature with a goal toward developing gene therapy of obstructive sleep apnea. Dr. Polotsky's career has been dedicated to studies of the pathogenesis of sleep-disordered breathing and its complications, and he has been continuously funded by the NIH since 2002, which is a huge accomplishment. Recently, he became involved in research into opioid-induced respiratory depression, or ORID, and is the recipient of an R61, R33 grant funded by the NIH HEAL program to develop a novel treatment for ORID. Dr. Polotsky is very well published. He's served on multiple NIH study sections and on the editorial board for several journals, including Frontiers in Sleep, the American Journal of Respiratory and Clinical Care Medicine, and the European Respiratory Journal. For perspective, his work has been cited just shy of 16,000 times. Also, he earned his MD and PhD from St. Petersburg State Pavlovsk Medical University in St. Petersburg, Russia, and he's a former chair of the American Thoracic Society Sleep and Respiratory Neurobiology Assembly. So with that, I turn it over to you, Seva. Thank you.
Thank you very much for introduction. And it's my pleasure to present, and thank you for inviting me again. So, and with this, let me start my presentation. And you can see my screen, right? Perfect. Okay. I have no conflicts. And my task today is to talk to you about sleep disorder breathing, about the mechanism of sleep disorder breathing, consequences or amelioration or treatment. First, we'll talk about mechanism. Most common form of sleep disorder breathing is obstructive sleep apnea. What is obstructive sleep apnea? Obstructive sleep apnea is a recurrent closure of the upper airway when we sleep. This condition leads to intermittent hypoxia, intermittent drops of oxygen level in blood, pressure swings, transthoracic pressure swings, fragmentation of sleep, and hypercapnia or buildup of CO2. This is a typical screen shot of the sleep study, which Dr. Jain and I look at this almost every day. And as you can see here, it's the I leads here and the EEG leads, EMG, EKG, and this is oxygen tracing and airflow. This is airflow and effort. As you can see that this patient has intermittent severe drops in oxygen level in the blood. Why is it happening? Because the flow stops while effort continues. So basically patient cannot breathe because the airway is closed. The effort continues, but the air doesn't come in. It's an incredibly common condition. Obstructive sleep apnea, diagnosed by apnea-hypopnea index, number of time breathing stops per hour, greater than 5, greater than or equal than 5. It's present in 54 million patients only in the United States, close to 1 billion patients in the world. Moderate to severe apnea with significant health consequences is observed in 24 million patients in the United States. In obese individuals, it's even much more common, and its prevalence in the neighborhood between 50 and 80%. So what are the traits contributing to sleep apnea? First of all, it's compromised upper airway anatomy. So without this compromise, it will not happen. Then poor protective neuromuscular reflexes. It's very easy to understand. Nobody has apnea awake. Why? Because the neuromuscular reflex is protective. When they don't protect, they develop apnea. And two, I would say secondary, but also important disturbances, they should be present. Or can be present, dysfunction of the control of breathing, which leads to overly sensitive compensation to breathing cessation. Or just opposite, sluggish compensation. Both extremes are bad. And low arousal threshold. That will become more clear from subsequent slides. Obesity leads to upper airway adiposity, which predisposes to obstructive sleep apnea. This is upright, awake MRI of the upper airway. This is the tongue. And in a lean, normal weight individual, and you see the tongue in obese individual, there is a fat accumulation in the tongue and fat accumulation around the pharynx, which results in narrowing of the upper airway. But the breathing does not stop when the patient awake. When patient is asleep, and this is fundamental paper, one of the most commonly cited in sleep medicine, a paper published in 1978, it shows that when they have mechanical load imposed by obesity, airway is starting to close. But if you have robust reflexes, you're able to protect. See, protection. If it doesn't happen, airway collapse. Now, as I said, that another important phenotypic feature is control of breathing or loop gain. So let's say airway collapse, but our response or patient response is appropriate. Then the breathing sooner or later stabilizes. What if there is an overshot? If breathing overshoots, what's happening? The CO2 is being blown away, which leads to more collapsibility of the airway and decreased central control of breathing, decreased desire by the desire to breathe. And the breathing becomes unstable. That's called the high loop gain, because when a response disturbance is higher than disturbance itself. Finally, arousal threshold. So there are two extremes here shown. One extreme, the oxygen level dropping down very low, it's even lower than, and nevertheless, the patient does not wake up until oxygen level drops to dangerously low numbers. This is lowered arousal threshold, but when it, which is detrimental, but arousal threshold is very high, meaning the minimal disturbance here happens. Airway just a little bit compromised. Nevertheless, you wake up. That becomes also really leads to instability of the airway and frequent obstructive apnea. In the first phenotype, the usually obstructive events prolong and may not as frequent, nevertheless very detrimental because oxygen level. And second condition is also detrimental because of the inability to sleep. What are the consequences of sleep disorder breathing? Well, that's the most important outcome, isn't it? Mortality. Indeed, sleep disorder breathing leads to high mortality. This is essentially survival probability, Kaplan-Meier curves, in patients who are stratified according to the severity of sleep apnea. Here it's a black broken line here, represents normal individuals without significant apnea. This mortality over 10 years period of time. This is sleep heart health data I should mention to you. It's a very large community study. As you can see, as apnea hypopnea index increases severity, so does mortality. Turns out that what's really predictive of mortality is oxygen level. So the hypoxic burden, that's a recently introduced criteria of sleep apnea severity, although it's kind of obvious, intuitive criteria, because you can stop breathing for short period of time, or you can stop breathing frequently without drop of oxygen level. You will have high apnea hypopnea index, but not much hypoxemia or low oxygen. So here it shows that if you calculate this area under the curve, how low oxygen go for how long, this is called hypoxic burden. And that's really what correlates very tightly with mortality, the degree of desaturation. Not only how many times you stop breathing, but how far you desaturate. Sleep disorder breathing, as I will explain in details a little later during the talk, leads to chronic increase in mortality due to predisposed to chronic morbid conditions. But also there is significant change or increase in acute mortality. This is actually another landmark study published in New England Journal of Medicine. This is a study from Mayo Clinic, where they look at the prevalence of sudden death. Normally, almost commonly, sudden death occurs between in patients who do not have sleep apnea or during early morning hours. It's most common between 6 a.m. and noon, as it's shown here. Well, this distribution changes dramatically in sleep apnea, and most of these patients actually die at night. We can only guess that this may be associated with severe hypoxic episodes or arrhythmia. Sleep apnea imposes a huge burden on public health. The total societal level cost of sleep apnea is more than 100 billion a year in the US alone, including 87 billion of loss of workplace productivity, 30 billion due to increased healthcare use, and 26 billion due to motor vehicle accidents, 6.5 billion due to workplace accidents. It's a huge, multiple disasters, very well publicized, very well known, been related to sleep deprivation or to sleep apnea. So what are the outcomes? Well, the outcomes are multiple. Even more recently, we actually found not only metabolic outcomes or neurocognitive, but also increased prevalence on certain types of cancer. Turns out that cancer surprisingly associated with sleep apnea severity and hypoxia severity. It's actually melanoma and renal cell carcinoma. But more commonly known and stronger evidence on association or causation, the matter of fact, between sleep apnea and cardiovascular metabolic outcomes. Increased risk of arrhythmia, especially atrial fibrillation, systemic hypertension, type 2 diabetes, fatty liver disease, hyperlipidemia, atherosclerosis, coronary artery disease, stroke, as well as pulmonary hypertension. So it's finally, at last but not least, definitely, it's neuropsychological and cognitive outcomes. Poor nocturnal sleep, daytime sleepiness, cognitive impairment, apparently increased risk of development dementia with aging, motor vehicle accident, and impaired quality of life. So this graph, this is data from very large study in Sweden. They show the prevalence of motor vehicle accident in patients with sleep apnea compared to patients or subjects without apnea. This is number of accidents per 10 years of observation. They have a lot of accidents even in patients without apnea in Sweden. I was kind of a little impressed, 12 accidents per 10 years. But if a subject has a sleep apnea, it goes up almost threefold. And the same for all the age cohorts and for all the individual as well. There is a very strong association between sleep apnea and risk of motor vehicle accidents. Sleep apnea predisposed to the development of hypertension, which is very well proven. In this study, this study from Wisconsin cohort, this is prospective study. So basically, they observe patients, they enroll patients and look at the patients who do not have hypertension and stratify them by levels of sleep apnea by quartile. And you see the quartile is a community distribution. So it's not the same as severity in patients. It's throughout the community. So as you can see that this patient essentially without apnea with minimal apneic burdens, less than 5 events per hour. According to our definition, there's no really sleep apnea here. Mild disease and moderate to severe disease, greater than 15 events per hour. You can see even the minimal increase in number of apnea, which is not even qualified for sleep apnea, results in increased odds of developing hypertension, and twofold increase in patients with mild and nearly threefold in moderate to severe apnea. The same significant risk of atrial fibrillation. You see patients with sleep apnea that much more commonly were diagnosed with atrial fibrillation than patients without apnea. Moreover, the patients in whom atrial fibrillation occurred after ablation almost invariably had a sleep disorder breathing. Sleep apnea is very tightly associated with stroke, and I will show you again a little later evidence for possible causation. And this is large cohort, more than 5,000 individuals in sleep health study, and look at the prevalence of stroke in men and in women. And in men, there is a very clear relationship between severity of apnea and adjusted survivorship function. That was a risk of stroke or death of any cause, and there's a significant increase in patients with apnea. Actually, in women, that was not observed. And we know that actually in sleep disorder breathing, it's very well recognized phenomena. The sex, especially in premenopausal females, it's protective. Over the last more than 2 decades, we recognize a strong relationship, at least a strong association between obstructive sleep apnea and insulin resistant and obstructive sleep apnea and type 2 diabetes. This is first 2 papers which describe it in large cohorts, but it's a cross-sectional study basically it's kind of like a snapshot relationship. But the prevalence of sleep apnea in type 2 diabetes is very, very high. As you can see, the different cohorts described in different studies. If you can see the Foster study, the relationship was the strongest. Nearly more than 8 out of 10 patients with diabetes had obstructive sleep apnea. The reason why relationship here is the strongest, because this study is actually, it's a look ahead study. Look at patients with obesity and diabetes. So obesity plus diabetes invariably associated with the, almost invariably associated with sleep apnea, and I can say invariably associated with sleep apnea in men. So what are the treatments, and what is the relationship between the treatment and the outcome? Well, there are different ways to categorize treatments, and my favorite way is kind of describe treatment according to the endotype or phenotype of sleep disorder breathing. It targets compromised upper airway anatomy. The most common cause of compromise of upper airway anatomy is obesity. So therefore, the weight loss is the first kind of intervention. And let's see whether weight loss is helpful to treat obstructive sleep apnea. This is a very large study. It was done in Australia, and they compared bariatric intervention, bariatric surgery, and this is the lifestyle modification, essentially diet and exercise, more diet than exercise. As expected, bariatric surgery led to much more dramatic weight loss, 20% weight loss. Less weight loss was observed in lifestyle modifications. And sleep apnea, it was helpful for sleep apnea in both cohorts. There was significant improvement. But look, it did improve from very severe to severe. So sleep apnea did not go away in the severe patient, despite dramatic weight loss. It's interesting that the lifestyle modification was very comparable, very similar improvement in sleep apnea, despite much less effect on weight loss. That's not entirely clear why, that probably other metabolic changes occur simultaneously when you modify lifestyle. But this is most remarkable take-home message for you. So what happens when you have mild sleep apnea? And mild sleep apnea, weight loss could be curative. So this is a large cohort from Finland, and shows that if a patient lost more than 15 kilos of weight, significant weight loss, that led to dramatic improvement in sleep apnea. This is mild apnea from 5 to 15 events per hour. So it's a significant improvement. And indeed, weight loss more than 15 kilos, most of the patients' apnea was cured. Well, there's no data so far. I know I kind of can predict this question about new drugs, GLP-1 agonists. There is no data. There is a large clinical trial going on whether there is a benefit for sleep apnea beyond weight loss. Well, most common therapy for sleep apnea is CPAP. That's actually a revolutionary intervention. That was, I think, one of most significant really intervention in medicine last century. In 1981, a physician scientist from Australia, Colin Sullivan, invented CPAP and published this in Lancet. So what does it do? And it blows air and classical CPAP in nasal passages and nasal mask, and splits open airways. This paper was cited nearly 4,000 times. And well, there's some, I would say, incremental improvement of CPAP. There's no dramatic development over the last 4 decades, but there was incremental improvement. 2 main types of CPAP treatment now. It's CPAP at the fixed pressure, continuous, constant set level of pressure. And this type of treatment requires special sleep study with a CPAP titration to establish therapeutic level of pressure, and automatic CPAP, auto-titrated CPAP. And in this case, after sleep apnea is diagnosed, patient just put on APAP without titration, and the machine adjusts pressure by itself, depending on the flow. So both these types of treatment and uncomplicated sleep apnea, they're pretty much equivalent. So what effects does CPAP have on consequences, on manifestation of sleep apnea? This effect of treatment with CPAP intervention on motor vehicle accidents. Well, I have to say a couple of words here about compliance with CPAP. There is an arbitrary criteria that patient has to use CPAP greater than 4 hours a night on 70% of the nights. It's entirely arbitrary criteria that was invented by a group of experts in the 90s when they just wanted to look at the effect of CPAP. And that was after it was basically adopted by Medicare based on this paper of the 90s. So as you can see, nevertheless, the patient who are compliant with CPAP has significant improvement in motor vehicle accidents, and the patients who were not compliant with CPAP, it actually was opposite. Okay, and this is the in this paper. Well, this is meta-analysis of multiple clinical trials or randomized clinical trials on the effect of CPAP on hypertension. So as you can see, nearly all the studies showed significant effect of CPAP treatment on hypertension. This is all comers on the left, all patients with hypertension and sleep apnea. And you can see the effect is modest, but it's 24 hours. 24 hours improvement in blood pressure, 2 millimeters of mercury, is actually associated with improved cardiovascular outcomes. But look what happened in resistant hypertension. What is resistant hypertension? That's when patient remains hypertensive despite being adherent to treatment with 3 or more antihypertensive medications. So if 3 or more antihypertensive medications do not work and patient is taking them, it's likely that sleep apnea is present, and in this case, CPAP may actually make a huge difference, 5 to 7 millimeters of mercury. Well, how about mortality? This is one of the also very widely, I think this is the most cited paper, at least it has been in sleep medicine. This is observational study, entirely observational, in Spain, which was published 20 years ago, nearly 20 years ago. So what they look at, again, Kaplan-Meier curves here, cumulative incidence of fatal cardiovascular events versus non-fatal cardiovascular events. And red line shows severe sleep apnea, and the other line shows different types of apnea, and the blue broken line shows sleep apnea treated with CPAP. As you can see that there was an association between sleep apnea. I emphasize association. It's an observational study, cannot study causation. There was significant association between severe apnea and fatal cardiovascular events and non-fatal cardiovascular events. And CPAP seemed to reverse it. Well, based on this data, there are several large studies were set up. It took many years to set it up. This is SAFE, International Multi-Center Randomized Parallel Group Open Label Trial. It's called SAFE. It enrolled 15,325 patients with coronary artery disease or cerebrovascular disease, and nearly 3,000 diagnosed with moderate to severe sleep apnea and were randomized to CPAP versus usual care. They were followed up for nearly 4 years. So, and CPAP group was 1,346, And this is multinational studies. It's actually predominantly, it was sponsored by ResMed. It was predominantly in Asia, Europe, and South America. There are some centers in the US. Well, that was very disappointing. Basically, SAFE showed no effect of CPAP on cardiovascular mortality and morbidity. Composite endpoint, death from cardiovascular cause, MI, stroke, hospital admission for heart failure, unstable angina, and TIA. We look at different ways and they still didn't see any effect. So basically, SAFE study showed no effect of CPAP on cardiovascular mortality and morbidity. Why is that? Well, CPAP adherence was only 3.3 hours per night on average. The disease was predominantly moderate. The AHI, apnea-hypopnea index, was less than 30. Patients were overweight but not obese, which is much more typical in the US. Based on BMI and oxygen desaturation index, the hypoxic burden was mild. And it was insufficient follow-up, probably 3.7 years. This degree of apnea, if it has detrimental effects, probably we can only guess it may take longer. But sub-analysis showed that CPAP adherent patient had a lower risk of stroke, which is an important finding. This is a different study. That was a European study, RICATSA. That's effect of CPAP on coronary artery disease in patients who are undergone either stent or bypass surgery. Again, there was no effect. And again, disease was predominantly moderate. Patients were predominantly overweight. And again, hypoxic burden was mild. Again, was low adherence. And again, adherent patient appears to benefit. And this is a large meta-analysis. It was published 3-4 years ago in the American Journal of Respiratory and Critical Care Medicine. Essentially combine these two studies, some other studies were combined, and they look at the combined outcomes. The primary outcome was cerebrovascular or cardiac death plus stroke plus MI. And apparently CPAP did improve that. About 32% improvement, that was statistically significant. Secondary outcome was borderline or significant. First ever cerebrovascular and cardiovascular event. But appeared to be there is a significant relationship with the decrease, almost twofold decreased risk of stroke. But there was no effect on cardiac outcomes or overall all-cause mortality here. So we can summarize that sleep apnea is highly prevalent in cardiovascular disease. Severe sleep apnea leads to cardiovascular morbidity and mortality, at least it's associated with cardiovascular morbidity and mortality. Hypoxemia, hypoxic burden, is a key contributor to cardiovascular disease and sleep apnea. Sleep apnea causes hypertension. This is proven. CPAP decreases blood pressure in hypertensive patients. And sleep apnea may contribute to the development of atrial fibrillation, stroke, and coronary artery disease. Randomized clinical trials and cardiovascular disease did not show benefit of CPAP for primary endpoint, but indicate benefits in cerebrovascular disease. And the studies were done only in moderate sleep apnea with mild decrease in oxygen. And CPAP adherence was poor, and the studies may have been not sufficiently long. How about diabetes? Does CPAP affect diabetes? Previously, at the beginning of my talk, I showed a very strong association. About 13 randomized clinical trials were done in different population of apnics, different outcomes, aside insulin sensitivity, glycosylated hemoglobin, fasting blood glucose and insulin. 6 studies showed some improvement and 7 showed unfortunately none. And again, that's a big pitfall of all the studies. Adherence with CPAP was low. This study, I showed a separate slide for that for a reason. In this study, patients were actually admitted as inpatients to the clinical research unit for 2 weeks. And they were essentially forced to sleep 8 hours with CPAP, or asked, rather, I should say, for 8 hours with CPAP. And this patient was pre-diabetes. So they didn't develop full-blown diabetes, but they had elevated fasting blood glucose between 100 and 125 milligram per deciliter, or elevated glucose after glucose challenge in oral glucose tolerance test. And there are 2 parameters here show the benefit. This is area under the curve of intravenous glucose tolerance test, show how body can handle glucose, was significant improvement in CPAP group, and this is placebo compared to placebo. And there was significant improvement in insulin sensitivity. But in this study, again, patients had to wear CPAP for at least 8 hours. This is probably one of the largest studies. None of the diabetes studies were really big. That was 298 patients with type 2 diabetes, increased hemoglobin A1C. Insulin was exclusion criteria, no previous CPAP treatment. And was CPAP versus usual care. And compliance was kind of just hair above the borderline for adherence for 3 months. And again, it was showed no effect of CPAP on hemoglobin A1C. So basically, we conclude that sleep apnea is associated with type 2 diabetes, but causality is not established. CPAP treatment may improve glucose control and decrease insulin resistance in compliant patients with prediabetes. Well, we talked about CPAP in details. So first of all, one thing I didn't kind of include the slide, but there is a consensus among the sleep physician expert that CPAP is still by far the best possible treatment. There is also BiPAP, bi-level ventilation, and there has no advantage and basically not advisable. Can be used sometimes for comfort, but we basically prefer CPAP in patients with sleep apnea. What if patients cannot tolerate CPAP? Adherence with CPAP is 50%. Oral appliance can be an acceptable alternative. Oral appliance is made by a dentist, and basically what it does, it's usually, there are several different types, I have to say, but this most common type. It has 2 pieces, one for the upper jaw maxilla and one for lower jaw mandibular, and the principle is very gradual advancement of the mandibular piece to open up retropharyngeal here space. So again, this treatment targets mostly anatomy, right? Like CPAP, splints open airway. This treatment also targets anatomy. Sleep study before and after should be done. Effective in mild to moderate apnea in non-obese patients. And patients should be under care of a sleep physician. And the appliance should be made by a dentist. It should be adjustable. Okay, so this is the very interesting slide, in my opinion, because it showed efficacy versus effectiveness. Efficacy is how helpful treatment is in ideal situation. And effectiveness, what's really happening in the real life. So look at the efficacy data. So this is CPAP and versus mandibular advancement device, or oral appliance, and percent of patients who report complete resolution of sleep apnea, much higher with CPAP, right? Much higher. So partial is better with mandibular appliance and failure high with mandibular appliance. But adherence to CPAP, as I said, 50% across the board, at least in the United States. And mandibular advancement device adherence is 70%. If you look at the real sample of patients, you can see that this is Epworth scale of sleepiness, effect on sleepiness score. Pathological sleepiness is more than 10. But any decrease is good. The lower, the better. And you can see that CPAP and mandibular appliance, they have about the same effect on sleepiness. And the same effect on blood pressure. Look at that. Effect on systolic blood pressure and mean blood pressure and diastolic blood pressure. And this is for oral for the dental appliance versus mandibular appliance versus CPAP. Actually, I realize that legend is gone somehow, but the dark square here, the dark field square, field oval here, it's CPAP, and open is mandibular device. It's about the same. So it's definitely acceptable alternative in some patients. How about surgical treatment? There are several surgical treatment modalities for sleep apnea. And again, it targets anatomy, anatomical predisposition to sleep apnea. So what are the types of surgery? Well, surgery on nasal cavity. So why is it important? Because if you don't have a nasal breathing, patient doesn't have nasal breathing, patients tend to breathe at night with their mouth open. And now imagine the mouth is open up. Open up, the mandible goes down. The amount of retropharyngeal space where the airflow is decreasing. So that's why when nasal breathing is improved, it improves sleep apnea. So, if you polypectomy, ablation of turbinates, it's all kind of has a, definitely has utility. If nasal breathing compromised, makes utility to fix the nose. Makes sense to fix the nose. So there are and septoplasty. The same with adenodectomy. So then oropharyngeal surgeries, tonsillectomy, UPPP, it's uvular-palatopharyngeal plasty, and this is the same but with the laser. Then the skeletal surgery, and this is very dramatic surgery with the expansion, basically rebuild and reconstruction of bony structures to improve, to increase the retropharyngeal space, including mandibular advancement, hyoid myotomy suspension, all pursues the same goal. And finally, this is at the bottom here. That's the only treatment we had before CPAP, before 1981. Patient with severe apnea, in order to save their life, they had to do tracheectomy. It's very, very rare now, as you can imagine. And that's just to show you what happens in different types of surgery. This is the airway, yeah, tonsils removed, tonsillectomy. This is UPPP. See, that's a big portion of soft palate and uvula removed. Well, tonsillectomy, adenodectomy, it's a treatment of choice in children. It's a big risk factor. And children, and some data, the non-obese adolescents and non-obese adolescents, it's also very helpful. And the polypectomy, septal nasoplasty can be helpful in adults. But UPPP, there is really no data that may be effective. There is no data. Now, skeletal surgery. How about this dramatic surgery I described to you? Well, in this case, the patient should, that may be recommended in patients with significant skeletal abnormalities, severe retronatia, it's most common, right? Or small low jaw. Patients are referred to craniofacial surgeon. They do kind of tridimensional reconstruction. This is relatively uncommon compared to huge risk imposed by obesity. Nevertheless, it may be helpful in a subset of patients. Okay, now if reflexes are dead, the patient will have no means to protect airways and will have apnea. And there is a treatment now for that. And treatment is novel treatment. Well, it's been approved by FDA already for 5 years or so. Electrical stimulation of the hypoglossal nerve. So who is it indicated to? The patient selection criteria, now they're a little bit more relaxed. Patient with moderate to severe apnea, but not too severe. I think AHI in an original study was less than 50. I think now they relax it slightly. BMI, body mass index less than 32. Now it's they accept patients with BMI less than 35. Very important on this relatively, you exclude patients with moderate obesity, greater than, and severe obesity, and exclude patients with very severe apnea. Then you refer this patient to ENT for drug-induced sleep endoscopy with propofol, and they examine the airway, laryngoscopy. We'll do this laryngoscopy during propofol anesthesia, and to make sure that there is no concentric collapse of the airway, which precludes this surgery, this implantation. And device, there are 3 types of devices now developed, but one is approved by FDA. I will talk only about this device, which is approved now and widely used. So this inserted here in the chest area, one thin lead goes to intercostal region just to sense the breath. If patient inspires, it delivers the more thicker wire, and he applied around hypoglossal nerve. And if you turn the device on, it will deliver stimulus, and that will result in protrusion of the tongue, basically sticking tongue out. And it works. It decreases pharyngeal collapsibility, relieves airflow obstruction during sleep anesthesia, improves sleep apnea. However, it works only in about 2/3 of the patients. And we don't know how to predict what this relatively relatively stringent criteria. A lot of patients included, but a lot of left out. And in this carefully selected patients, in 2/3 it will work. There's no way to predict. Right now, it's a main indication if you cannot stand CPAP. CPAP is treatment of choice. Patient will refuse to use CPAP, then we can refer this patient to hypoglossal nerve stimulation. So there's no FDA-approved drugs, but there are several promising candidates, and this is probably the most advanced. It's called eta-oxy. First of all, I'll tell you, in my opinion, the candidates will be very similar, will be competing, so to speak, with the hypoglossal nerve stimulators, similar population. And eta-oxy went through phase 1 and phase 2 clinical trials. What is eta-oxy? It's a combined drug. It's a norepinephrine reuptake inhibitor, atomoxetine, which is initially used for ADHD under the brand name Strattera, atomoxetine, and combination of antimuscarinic drug oxybutynin, which was approved historically for overactive bladder. Basically, these drugs were repurposed and combined. Pretty genius, I think. And I will not show you phase 1. This is much bigger. This is phase 2 trial. Just been published literally 2 months ago. Study, they call it Mariposa, and company name, it's an offshoot of Harvard, it's called Apnimed company. So, and 63 patients were in placebo arm, 63 were atomoxetine alone, 42 patient combination low dose, and 41 patient combination higher dose. And placebo had no effect, as expected. There was effect in all three groups, improved from 19 to 12, 19 AHI from 19 to 12, 20 to 11, 19 to 10. Well, obviously patients with moderate, kind of mild to moderate sleep apnea, was an improvement significant, but not really super dramatic, but significant. There are side effects. It suppresses REM sleep, increase N1 sleep. Dr. Jain just told you, N1 sleep is not such a great sleep, and increase arousals. No significant change in sleepiness or quality of life. May be contraindicated in benign prostate hyperplasia, and just because oxybutynin. Patients with heart disease were excluded, concern about norepinephrine, increased level of norepinephrine. Patient with hypertension on 2 or more drugs excluded because of, again, concern for norepinephrine effect. Okay, so let's talk about very briefly about 2 other physiological traits. I said this is 2 important traits: anatomy and poor reflexes, and we have targeted therapy, which is approved. Well, a dysfunction of control of breathing for when patient is responding too much to stimulus, to the airway closure. So it turns out that carbon anhydrase inhibitors are helpful. The first historical drug, which is widely used, acetazolamide, which is very well known and used in as a diuretics, as a mild diuretic, and also used in inpatients predominantly, with some outpatients. Also used to treat mountain sickness because it improves, stabilizes breathing. This is related drug, carbon anhydrase inhibitor, sulthiamine, and which basically stabilizes breathing. It doesn't do anything to reflexes, but it stabilizes the breathing. Apparently, may be helpful. Decrease in apnea from 61 to 40, about 55 to 33. This is not the level of AHI. This is decrease. So there is some benefit. And finally, low arousal threshold. If patients wake up to very mild stimulus, they may develop significant disease. Again, this is should be used very carefully. And some physicians consider using sleeping pills with CPAP together. But in this case, they measure apnea threshold in the lab and prescribe azapiclone to patients who had a low arousal threshold, who were waking up to very small change in airflow, and apparently they improved. So basically, you can see a lot of different interventions and a lot of work for doctors. So we should develop personalized therapy, which is a difficult task. See, Ms. Truly, we want you to relax, get a good night's sleep, and we will evaluate any sleep issue you have, and they'll prescribe the treatment. Hopefully, it will be effective. Thank you for your attention.
That's great. I have to say that that really reminds me of my time in the sleep lab when I had to convince participants that, yes, you are going to get a good night's sleep here in this strange environment with all these wires on you. So thank you very much for that, Seva. That was wonderful. We are going to take a quick break, 5-minute break. So if everyone returns back at 2:55 Eastern or 55 after the hour, or wherever you are, we'll see you shortly. All right, we can go ahead and get started again. I'm just going to briefly introduce the next introduction for our speaker. And this is Dr. Andrew Heyman, who is the director of the fellowship here in integrative medicine. But even perhaps more importantly, he's the founder of the integrative medicine programs. So over to you, Andy.
Thanks, Lee. I have the pleasure of introducing Dr. Lauren Hablitz. She's a circadian biologist and principal investigator of the Hablitz Lab and an assistant professor in the Department of Neurology, Center for Translational Neuromedicine at the University of Rochester Medical Center in Rochester, New York. She earned her BS in biology from the Pennsylvania State University in 2010. And in 2015, Dr. Hablitz earned a PhD in cell, molecular, and developmental biology from the University of Alabama, Birmingham, from the lab of Dr. Karen Gamble, investigating conserved molecular mechanisms of non-photic entrainment. After completing a postdoctoral research position at Oregon Health and Science University with Dr. Charles Allen, understanding the role of astrocytes in modulating cannabinoid signaling in the suprachiasmatic nucleus, Dr. Hablitz joined the Center for Translational Neuromedicine at the University of Rochester in 2017. Together with Dr. Micah Nedergaard, Dr. Hablitz defined the endogenous circadian rhythm of the glymphatic system and discovered a new rhythm in CSF distribution between the brain and the body. In 2020, she earned the Society for Research on Biological Rhythms 2020 Merit Award. She's a 2021 recipient of the Sleep Research Society's Outstanding Early Investigator Award for circadian control of brain lymphatic and lymphatic fluid flow, which was published in the journal Nature. So thanks so much for joining us today. It's wonderful to have you.
There we go. Hi, everybody. Thank you for the kind introduction and for the welcome to be here today. As they so eloquently described, I am a circadian biologist, so I ask a lot of questions about timing and when we do things. But today I'm going to switch that a little bit and talk about sleep and why we sleep and how our lab views sleep. And so what you'll actually see on this screen here is a picture of a mouse brain where we just took the skin off the top of the skull and put dye into the cerebral spinal fluid. And you can see it goes really nicely up the middle cerebral artery. And this is an anesthetized mouse that is fully alive under a microscope. And so what our lab has really been interested in is how does this system that enables cerebral spinal fluid into the brain work? In what conditions is it impaired, and how might we fix that? And so normally I start with a big question, and that's why do we sleep, which I think fits great with this symposium talk right now. Sleep is evolutionarily conserved. It's flies, it's mice, it's my creatures on the bed, and it's literally everyone that's in this audience. But as far as like the sleep biology side of things, the first speaker did a wonderful job of saying reasons why we might sleep. What my lab and our research group focuses on is we may sleep to clean the brain. Being awake is extremely energetically costly. We have to interact with the world that we live in, and our neurons get tired too, and they start producing waste just like our muscles would if we overexercise them. And so we need a way to get that out of the tissue. And so, working with Dr. Nedergaard, there's this hypothesis of the glymphatic system. So in the periphery, if you do exercise a lot and your muscles hurt a lot, the lymphatic system takes over and pulls the lactic acid from the tissue. But the brain doesn't have the lymphatic system. Instead, what it has is a thing here on this screen. You'll see blood vessels that are red to blue. That's arteries to veins. That's how blood travels. But what you should also notice is that in the brain, there's actually spaces around the blood vessel, the perivascular space, where fluid can actually fit down. And so these are actually kind of homologs to how the lymphatic system works, because once the blood starts pumping, cerebral spinal fluid can get pushed into the tissue to help clear all the waste from the neurons and ultimately pull it down the perivenous space to the periphery. And so I'll say the perivascular space has been known since the 1800s. Actually, the hypothesis that this worked well in sleep has been suggested since like 1890s. The biggest problem is it's really hard to see these spaces, right? Because you're looking at clear cerebral spinal fluid going into an organ that's surrounded by the skull into really small spaces. And so, the topic of perivascular spaces came up in the 1890s. It came up in the 1930s. It came up in the 1950s, the 1980s. And every time people are like, we don't know what to do with this yet because we don't know how to see it and how to look at it. Until Dr. Nettergaard's beautiful paper. And so the seminal study that they did was they trained mice to sit underneath a microscope. We use 2-photon microscopy. We can get pretty deep in the tissue, which, considering we're trying to image in a brain surrounded by a skull, this is really impressive. The two people, Hung-Yi and Lulu, that did this experiment actually trained these animals to sleep or to wake underneath the microscope naturally. They put dye into the cisterna magna, which is this little purple needle on the screen here, putting it into the cerebrospinal fluid to actually be able to travel through the brain. And this is the images they got, right? You'll see blue is actually blood vessels. You'll see two conditions here. You'll see wake and sleep. You'll see a green tracer and a red tracer when I start the video. And what I hope you can appreciate is in the red video, a lot more red tracer gets into the image screen and starts lighting up those blood vessels than during the awake state. And so this was really the first evidence where someone could look in the brain in real time and say, wow, cerebrospinal fluid and dye in cerebrospinal fluid can get really well into the brain when we sleep. They followed it up with another study that Dr. Jain presented really nicely, where they could show that radio-labeled tracer got out of the brain when we slept. So not only is it fluid going in, but it's also fluid coming out of the brain that increases while we sleep. Everyone might be thinking, okay, I mean, maybe you don't think about sleep deprivation, but this is about sleep. And so we want to know, if we lose sleep, does the system get impaired? But the other question is, does this happen in humans? And so there was this great study by a group of Norwegian MRI biologists. And what you'll see here is 3 different sections of the brain after gadolinium infusion of tracer after a patient was awake or allowed to sleep for 24 hours. And so here is the patient able to sleep. Where it's red, there's dye in the brain. Where it's blue, there's less dye in the brain, or radio-labeled tracer, sorry. What I hope you can appreciate is there's a lot more red in the sleep-deprived brain of the patients that had to stay awake for 24 hours. And so this study was really important because it was the first time, first of all, we showed that if you lose sleep, the system gets impaired. But second, we can see this active in real time in a patient population. Dr. Ida and Ringstadt's group has continued this work. It's really fun watching them go. A lot of their stuff has to do with, okay, how does this change in different disease models? They're really interested in normal pressure hydrocephalus and stuff like that. But where are we taking it? Why am I telling you about this story today besides sleep deprivation? One thing I want to introduce is the idea that sleep is important, not just to clean the brain, but also to help keep our brains and ourselves healthy. And one great example of that is the relationship between sleep and pain. And so what I hope you can see here is that this research group kept animals awake for different periods of time. And after they kept them awake for 6, 9, and 12 hours, they started doing testing on pain sensitivity. And so here you'll see hot play with draw. If you keep a mouse awake and put it on a heat pad, it'll put its paw on the pad and it'll go, oh crap, it's hot, and pull it back. And you'll notice that in the red group, the one that had been awake for 9 hours, they pull their paw back faster because they notice it's hot faster. So this is increased thermal sensitivity to pain. They also did a von Frey test. And so this is if they take a mouse paw and they start poking it, how fast does the mouse realize it's being poked? And what you'll see is the red line is above that white line again. It means that it really takes less for these animals to realize they're being poked and realize that they're in pain compared to a group that's been able to sleep just fine. And then the final thing they did was inject capsaicin into the paws of these mice. So if you guys have ever cut jalapenos and you notice your hands start burning, that's because of capsaicin. It's a spice protein that ends up turning on pain receptors in your fingers. And so this happens in mice too. And what they notice is that the sleep deprivation group starts getting really, really irritated more than the group that slept. And so now we know the brain is cleaned during sleep. We know that if you lose sleep, you're not able to clean the brain. And we know that if you start messing with sleep, you start changing how you see pain. And so how do we put all of these things together? What is the connection between pain, sleep, and glymphatic function, right? We started testing this, and the first thing we just asked was, what happens if we do a chronic injury model in a mouse. How do they respond to pain and what happens to the glymphatic system, right? Overall, here's how we think it works. We would cause tissue injury and inflammation, which would keep the animal awake, which would impair glymphatic clearance. That's all pretty straightforward. But then the brain has to start responding to the fact that the waste isn't getting cleared from the tissue. Like your brain is dirty, and so what ends up happening, you start getting an immune response, your astrocytes start reacting with gliosis, and your neurons start noticing that stuff is wrong, and so electrical signals start getting remodeled. And that's when you start getting chronic pain. Once, even after the tissue injury is healed, your body can remember it was in pain, and we know that pain can cause sleep disruption. But this is a circle. So how do we start testing it? Because, you know, it's great to have a model and we're pretty sure that this works correctly, but where do we start teasing this apart? Is glymphatic function reduced in a model of pain? And so this is what we did. We use a spared nerve injury model where we actually cut the tibial and peroneal nerve in the sciatic nerve. And so these animals start experiencing pain in their back legs because we ended up trimming the nerves. What you'll see here is that same von Frey test I showed you earlier. This is plotted a little differently, but you can see once we give the surgery, the animals don't need as big of a poke to pull their paw back. And this can actually last for over 3 weeks. And so what we did is at 3 weeks, at that long-term point where the body is starting to heal itself, but the animal is still showing a pain response, we wanted to ask, how does dye get into this glymphatic system better? And so we did that same experiment before where we put dye into the cisterna magna, the cerebrospinal fluid pool. We let the fluorescent tracer sit for 30 minutes. We took brain sections and we looked to see how much fluorescent tracer got in with these animals that had a model of pain. And so here's what we find. If you're ever wondering what a coronal section of a mouse brain looks like, here's what it is. I hope you appreciate that there's a lot of white in this brain and they look like really linear pieces of white. That's because that's actually the perivascular space getting lit up by cerebrospinal fluid. And here's what the SNI brain looks like. And so there's this thing that happens where after 3 weeks of getting this spared nerve injury model of pain, lymphatic influx is declined. And, you know, we have a low sample size here, but this was also replicated in one of Dr. Nedergaard's preliminary works when we started this project. And so cool, we know pain can impair lymphatics. And so we go back to this model and we start asking, what can we do to actually restore glymphatic function? Can we reduce neuroinflammation to restore glymphatic function? We went in a different direction from what labs normally go into. Dr. Nedergaard had a beautiful paper that showed that if you give acupuncture to a mouse in its leg at ST36, the animal actually has an acute adenosine response that causes a local change in immunoreactivity that ends up releasing pain or reducing pain. And so our question was, if we start doing the same acupuncture technique locally in the same section, do these animals still have a change in glymphatic function over time, or can acupuncture decrease enough of that immune response to start recovering glymphatic function? And so we did the same test where animals had the SNI surgery. What I hope you notice this time is we don't do the experiment until 36 days after the surgery. So by now the animal actually is healing from this. Instead of the 21 days I showed you earlier, we looked at how well dye got into the brain. And this is what we found, which is a little messy, but that's okay. That's science. That's how we deal with it. The first thing you notice is that something happens at 36 days where we have increased variability in glymphatic function, but it's not as decreased as it was at 21. So there may be a time frame of when the brain is actually decreased and how it deals with that. We're looking into it. But the other thing I really want you to appreciate is that especially in the SNI group, we get an effective acupuncture and it recovers glymphatic function. And so now the question became, is this real? Is this a stress response of the animal? What is acupuncture actually doing here to the glymphatic system? And so now we're going to switch gears a little, right? We looked at, okay, pain can impair lymphatics. Acupuncture may be able to recover it. But now we just need to know if this works in healthy animals, or is this a combination of like stress and sleep deprivation and glymphatic dysfunction and pain that's causing a weird response when we give acupuncture on top of that in animals. So can this work in healthy animals to promote good lymphatic flow? And so we did 2 different things in this experiment. You'll notice we gave acupuncture for 2 weeks again, but these are healthy animals. So we say day 1 to 14. We used that same point in the leg that we were using before. And we also used a control one in the foot. So this way we know if it's specific to the one that actually feeds the lymphatic system that's near the part in the sciatic nerve that would get damaged, or if this is just us sticking a mouse in the foot and it getting mad at us. We did that same experiment where we put dye into the cerebrospinal fluid and let it go into the brain, and we found absolutely nothing, which is actually pretty cool because if you go to talk to acupuncture researchers, acupuncture doesn't always work in healthy individuals. It actually needs to have a it needs to have an inflammatory response to actually be able to work. And so our data actually kind of proved this in that in a healthy animal, acupuncture doesn't change how the brain functions. You know, it may have an effect locally, that's what Dr. Nedergaard shows, but the combination between the periphery interacting with the brain is disconnected if the animal is healthy. Okay. But I am a circadian biologist. This acupuncture was a fun, different way to think about how the periphery could interact with the brain. And so I wanted to get back to timing, right? We talk about timing of sleep, but we also have timing of a bunch of other things too, like eating. And the circadian field especially is really interested in how does giving food at the right time of day change how the brain works, and how does food change how disease works? And so we just asked a really simple question of if we give food when the animal should be awake compared to if we give food when the animal should be asleep, how does that actually change how the brain works, right? Does it change lymphatic function? And so what you'll see here is we gave 8 days of restricted feeding. And then we did that same lymphatic influx that we saw before. And here's what it looks like. So here is the control animals where we had normal amount of lymphatic influx. Time restricted feeding actually increases how well food gets into the brain. So when we give food when it should be there, dye gets in better. And that could be because if you think of a sine wave across the day, sleep would beef it up on one side and food may tamp it down on the other. So the amplitude of that is bigger. And so when we start looking about how well lymphatics works, if we give food at the right time of day, we end up getting more lymphatic influx. What's even more interesting is we started to ask if we screw up rhythms, do we end up screwing up the lymphatic system? And right now, it doesn't necessarily look like it. We gave food when the animal should be asleep. This is normally not when they eat. For mice, if you give them food when they should be asleep, they binge eat for like 2 or 3 hours and actually deprive themselves of sleep, and then they crash. And their whole activity cycle delays like 2 hours. But we don't see that reflected in the lymphatic influx. If anything, we're starting to trend toward an increase like we do with the restricted food during the active phase. And so one of the main goals of my lab going forward has really been thinking about how do we reconcile disrupting rhythms hasn't changed influx with some of our genetic models where if we do it genetically, if we break time in a cell, we start getting lymphatics unchecked. And so now we're trying to tease apart what is this sleep deprivation and sleep need part of how the brain clears waste versus what is the timing need of how the brain clears waste. Okay, tangent, it's fine. And so what have I told you guys about this far? This went a little faster than I thought it would. I am terribly sorry. But basically, we know tissue and injury and inflammation causes acute pain. We know that ends up depriving the animal of sleep, which can impair lymphatic clearance. And we know that ultimately, if you impair lymphatic clearance, you end up triggering a neuroimmune response that increases cytokine productivity, changes excitation of the neurons, and ends up with maladaptive circuit remodeling that can influence chronic pain phenotypes. And we know chronic pain can impair sleep, especially if you look at epidemiological data. Most pain peaks in the early evening, so patients have a big problem getting to sleep, and then patients with back pain end up waking up really early because they're in pain. And so what did I tell you today in terms of data? The glymphatic system cleans the brain during sleep. Dr. Nedekard beautifully illustrated that dye can go into the brain and radiolabeled tracers can come out of the brain. Paraida's group showed that if you sleep deprive a human, you can actually have retention of gadolinium dye in the brain. If you look at the work by Laura Lewis and colleagues, they're showing really nicely that cerebral spinal fluid kinetics across the brain actually change a lot during sleep. And it might be how the blood flow is interacting with the brain, which is another connection between the periphery and how the brain handles stuff. If you give sleep disruption, you decrease glymphatics and increase pain. And similarly, if you cause a chronic model of pain in mice, we start to see glymphatic function fail. And then finally, we may be able to have a peripheral reduction in inflammation help clear what happens in the brain and increase glymphatic influx. But this is only in animals that have had S&I. We don't see this in healthy animals. And then finally, you know, sleep and circadian rhythms end up interacting. And if you help circadian rhythms, maybe by giving the animal food, you can also increase glymphatic function. Probably because if you restore the rhythm correctly, the animal is also sleeping the way it should. And so what do I want you guys to really take home from this whole little spiel that's a little bit different from what we've seen so far? One thing that's really interesting about the glymphatic system is pretty much any disease model you look at has an impairment of glymphatic function. And so we have a couple listed here. Things like aging and things like inflammation have been pretty well shown to decrease glymphatic function. These other ones are kind of question marks. We know respiration can change how well cerebrospinal fluid gets out of the skull, but we don't really know how that affects the brain tissue. We know that patients with depression may have impaired glymphatic function, but we don't really know why. And there's a huge push to understand how the cardiovascular system in the periphery interacts with how the glymphatic system works in the brain, because a big part of the glymphatic system is hijacking the blood vessels to push in cerebrospinal fluid into the brain. One thing my lab has really been doing is looking to see how changes in glymphatic function after stroke may be regulated by cytokines. And this inflammation may change how we see pain, which is a whole different thing, which can impact sleep quality. And so the take-home message of today's talk is really, we need good sleep to keep our glymphatic system in order, but also if our glymphatic system starts failing, that may drive how we sleep. And I know I ended a little bit early. I'm terribly sorry, but I want to say thank you, especially to the people that helped with the S&I and acupuncture work. Those are highlighted in orange, and my collaborator, Dr. Neddergaard. I wanted to thank my funding sources, and most of all, thank you for your attention.
Thank you very much. It was an excellent talk. And just wanted to ask a quick follow-up question, since we do have a little bit of time. One of the trends I think we've been talking about during this is that we have sleep deprivation being bad. When I first heard about the glymphatic system, that was kind of like an aha moment for me. Do you think that maybe this is driving a lot of those relationships, and maybe give us some thoughts as to how we can remedy that?
Yeah. So I think Paraida's group showed beautifully that if you sleep deprive a human, the glymphatic system tanks. And there's been a lot of literature that shows if the brain starts getting healthy, the glymphatic system tanks. My question recently has been, is there a continuum to glymphatic function? Because this is how the brain cleans itself. And you can imagine if this fluid plumbing system is going too fast, it's going to start pulling the tissue with it. And so one of the things, in terms of sleep deprivation, yes, sleep deprivation is going to impair our system. We may be able to fix blood flow to fix that. We may be able to, you know, manipulate some like peripheral stress responses to fix that. But I think the field has a lot to do in terms of when do we start seeing glymphatic dysfunction, especially in terms of chronic sleep disruption. And is it always a downhill, or is it like a peak that troughs? I hope that was an answer.
Yeah, absolutely. And I think this will probably be relatively new to many of our listeners, unless they listen to the podcast episode that we did with Dr. Jain. I could give them a bit of a sneak peek, just because one of the things we talked about in the podcast is that a lot of people just, and even in my family, I've heard this statement, I'll sleep when I'm dead. And I think we're realizing that that's not at all how this works. Like, you need to sleep so you can live and enjoy the life that you have. And hopefully this will help people prioritize sleep.
Yeah, definitely. And I'll say, the UK has actually started, or not the UK, Europe, some places in Europe have actually started putting protections in from shift work, and actually have been giving hazard pay for shift work, because of the idea that we kind of need sleep to survive.
Yes, it's clearly quite important. All right, well, thank you so much.
Thank you.
We will go ahead and get ready and move on to the next speaker then. And I am doing this introduction. Okay. So Dr. Liza Ashbrook is a neurologist and associate professor of neurology in the Weill Institute for Neurosciences in the School of Medicine at the University of California, San Francisco. She's also the director of the Sleep Medicine Fellowship Program at UCSF. Dr. Ashbrook's research focuses on understanding the genetics of extreme circadian traits and extreme short and long sleepers, as well as characteristics associated with these sleep and circadian phenotypes. A recognized expert in her field, Dr. Ashbrook speaks frequently nationally on common sleep disorders such as sleep apnea, excessive daytime sleepiness, insomnia, restless leg syndrome, and REM sleep behavior disorder, and their relation to Parkinson's disease. She also gives talks on sleep and women's health. Dr. Ashbrook earned her medical degree and completed her residency at UCSF. She completed a fellowship in sleep medicine at Stanford University. Dr. Ashbrook is a member of the American Academy of Neurology and American Academy of Sleep Medicine. Her research has been published over 90 times in scholarly peer-reviewed journals, including the journal Neurology. A practicing physician, she treats neurology patients suffering with sleep disorders at UCSF and the VA. So thank you very much for joining us, and I will turn it over to you. Oh, I can't hear you. We heard you earlier. Anyone else here? It's not just me, is it?
No, we can't hear her.
Okay, thank you.
No. That's something with a mic probably.
Yeah, probably the audio options.
Yeah.
These things have a mind of their own.
All right. Are you able to hear me now?
Yes.
Yeah, my apologies. Wonderful. Okay, so thank you so much for having me. It's such a pleasure to be here to speak with the group. I'll go ahead and share my slides. All right. So I am thrilled to speak with the group about human circadian variation, specifically directed about personalizing sleep care for well-being. So we are going to focus today on sleep timing. You've already heard quite a bit about the importance of the quantity of sleep and things that might impair the quality of sleep, namely sleep apnea. But these are three things that are really vital to making your sleep good, which is something, of course, we're all striving for. So when we think about sleep timing, many times people will think about morning larks and night owls. And so you in the audience can think now, are you a conventional sleeper? Are you a morning lark? Are you a night owl? Some of the questions that are helpful to dive into this is, what is your preferred sleep timing when you're free of obligations? When you don't have other people telling you time to go to school, time to go to work, the need to take care of others or yourself? At what time do you focus the best? If you need to do a big project for work, when would you choose to do it? If you have to do a grueling workout, what time of day would you best perform? All of these can help you determine what your chronotype is. So let's talk, what is chronotype? This is a unique daily activity pattern for each individual, and there are a lot of factors that help determine your individual chronotype. So one is your circadian rhythm, and there's a big genetic contribution to that. But there are also environmental factors, lifestyle factors, and age. And so we'll dive into these. So this is a curve showing the variation of chronotype throughout the population from Till Roenberg's research. And you can see that there's a relatively normal distribution. So while most people are conventional chronotypes, there are people at the extremes on either end. And as we become more extreme, there are fewer and fewer individuals. And this is based on the mid-sleep time that's corrected for compensated or corrected for work week sleep deprivation and for sex and age. So when we think about chronotype, a really important component to talk about is circadian rhythm. What is circadian rhythm? So this is an endogenously generated rhythm of circa a day, as many in the audience I'm sure know. And it's so vital to living organisms because it helps us anticipate what is happening next. When should we expect to eat? When should we expect to sleep? When should we expect to be safe? When should we expect to have to protect ourselves? And so much of our body really functions based on time of day. Our liver needs to know if it should expect to produce sugar to avoid hypoglycemia, or if it should expect food input during that period of time. So you might imagine that our brain's internal rhythm is exactly 24 hours to match up with the day. Interestingly, on average, studies show that human circadian rhythm is just over 24 hours, or our period, as it's called, 24.2 hours. That there is certainly variation person to person. And it's our suprachiasmatic nucleus that is our central pacemaker. This is located in the hypothalamus, and it's important for controlling and influencing many bodily functions and their timing. So of course, sleep and wake is a component that we think a lot about, but there's also many other things, including the core body temperature, which is something that's often measured in clinical research surrounding sleep timing, cortisol release, appetite. And circadian rhythm has actually been described for centuries. A study done by a French scientist back in the 1700s on a mimosa plant shows both the longevity of the awareness of circadian rhythm and how it affects not just humans or animals, but plants and many, many species. So the mimosa plant, this scientist noted, had open leaves during the daylight hours in the sun and closed its leaves at night. So he then went on and moved it to an environment where it didn't have sunlight and noted that it continued to cycle in that same way. It in fact wasn't responding solely to the light, it was responding to the time of day. When we think about the circadian rhythm in humans and the function of the suprachiasmatic nucleus, a really important piece is thinking about what are the inputs to this rhythm. And so for humans, the really main input is the timing of light. And this is demonstrated when we think about these specific kinds of cells in the retina called intrinsically photosensitive retinal ganglion cells, or IPRGCs. And so right at the back of our eye, we have these cells, and they have a direct pathway to our central circadian pacemaker, the suprachiasmatic nucleus. And what's so important to note about these cells is that they have something in them called melanopsin, which is specifically sensitive to light in the 480 nanometer portion of the spectrum. So this is blue light, blue indigo light. So that's why there's so much in the popular press, in research, in many areas talking about blue light and how it can influence wake and sleep, because these IPRGCs in our retina are specifically responsive to blue light, and they have a direct pathway into the SCN. And then the SCN has many, many pathways out, including a multisynaptic pathway to the pineal gland. It is the pineal gland that releases melatonin. And so we can sometimes measure melatonin in an individual as a proxy for where the suprachiasmatic nucleus thinks it is from the perspective of time of day or proximity to sleep. So light is so important for our internal rhythm, but it's not just exposure to light haphazardly. The timing of light exposure is what is so vital. So we can see this with a nice diagram here on the left. So say one's typical habitual sleep period is kind of a conventional timing from 11 to 7. That means that the core body temperature minimum would be expected to be about 2 hours before natural awakening, potentially around 5 a.m. for this individual. And then dim light melatonin onset. This means when our body naturally starts to release melatonin in dim light conditions is usually 2 or 3 hours before natural sleep onset. So the timing of our exposure to light can influence what time of day our brain thinks it is or where it should expect to sleep. Light in the early morning hours, in the last 2 or so hours of sleep and the first several hours of wake, has the impact of advancing our rhythm, meaning telling our brain, oh, hey, now it's daytime, and helping us to potentially fall asleep earlier. Light in the other portion of time, meaning the last several hours of the day and the first 2/3 or so of our night, has the impact of delaying us, telling our brain, hey, it's still time to be sleeping, and pushing our sleep period later. This is the depiction of the phase response curve to light. Time 0 here is our core body temperature minimum. So that's the time approximately at which this flips from light being something that delays us to light being something that advances us. For most of us, we are able to balance out light at different periods and stay on a stable schedule. But we really think about this timing when individuals are having unrefreshing sleep, having problems with their sleep timing. There's also a phase response curve to melatonin. So while light is the biggest input to our circadian system, melatonin can have phase shifting properties as well. As you know, melatonin is the hormone our body naturally produces in the dark during night hours. And the phase response curve to melatonin is about 12 hours out of sync with light. However, in this period of time when our body naturally produces melatonin, it doesn't have significant phase shifting properties. But melatonin in the early morning hours can have the impact of delaying, at least in experimental conditions. And melatonin in the few hours before our body naturally releases its melatonin can have the impact of advancing our rhythm. So we'll often recommend this to patients who are having trouble with what we call delayed sleep phase, having trouble falling asleep at the desired time and trouble awakening because their rhythm is later than their desired sleep time. You can actually take a low dose of melatonin early before dim light melatonin onset and pull the rhythm earlier. Typically, we recommend a small dose, 0.5 milligrams, which is closer to our physiologic dose, what our body might release. Interestingly, when I see patients in sleep clinic and people are often come in taking melatonin and doses vary widely. But I think it's very important to keep in mind, while melatonin is often taken as a sleep aid to help with sleep, it does have these circadian shifting properties. So for example, if one took 10 milligrams of melatonin, it actually has residual effects in the morning. And if you're trying to take it to pull the rhythm earlier, there may be a spillover effect, and it's actually less potent to do this. So I wanted to share this study by Ken Wright and colleagues from about a decade ago. It's a very small study, but I think it does a great job of illustrating the impact of light on our sleep. So he had individuals sleep in 2 different environments: in their natural environment with their typical amount of artificial light, and then camping without artificial light. And this on the right here, you can see, is a actigraphy. So actigraphy is like a medical grade Fitbit. It collects information on light and movement. And so you can see their first week. This is just a single individual who's representative of the group. You can see the movement and light exposure. And then you can see in the second week, there's significantly more light as the individual was in an outdoor environment. And then they did a circadian phase assessment at the end of the first week and at the end of the second week. So let's look at what that showed. So here on the right, you can see the summary of that information. And to help orient you to what we're looking at, this black bar was the mean sleep episode, the timing of the mean sleep episodes for these individuals in the electrical lighting condition, just their typical life, and then in the natural light condition when they were camping. And you can see as a group, all the individuals moved earlier when they weren't exposed to all the artificial lighting and were exposed to natural light. Not only that, but you can see these error bars, they're much smaller. So there's a lot less variation person to person in this natural light condition. So even individuals who were rather delayed with a later sleep onset and a later sleep offset time moved significantly earlier and were more similar to their peers when not in the electrical lighting environment and instead in natural light. The final thing I think that's useful to highlight is the melatonin timing. So they measured melatonin onset, midpoint, and offset. And you can see for people sleeping in the electrical lighting environment, their melatonin offset, meaning, melatonin is released, and then when there's no longer melatonin detectable in the system, it's actually after they awaken on average, which means they still have some melatonin in the system when they wake up, as compared to those sleeping in the natural light environment. And so this might contribute to some of the sluggishness and sleep inertia that people experience often in the morning in our current environment. Here on the left, I think it's useful to look at this also from the same paper, which highlights how strong different light sources can be. A common term used to describe light in these studies is lux, which is a measure of how strong light is when it hits the eye. And so electrical lighting is often a couple hundred lux up to maybe 1,000. And then natural light, even on a cloudy day, it's 10,000 or more lux. So this scale is not linear. It's an orders of magnitude greater when you're having outdoor light as compared to electrical lighting. So it's not only light that can influence our rhythm. Other features called Zeitgebers or time givers are also important, though we think most about light because it is the main input to the SCN. But the timing of social interaction, meals, and exercise are important. And so we want all of these to line up when we're trying to optimize someone's sleep pattern. So our chronotype or our ideal sleep pattern can actually change throughout the lifespan. And I'm sure many of you in the audience are well aware of that. And I think it's nicely highlighted in this graph here. So this is a population study. The youngest age captured here is age 12. So you can see that younger individuals, and age is here on the x-axis, chronotype on the y-axis. The black circles are women and the open circles men. You can see that younger individuals are earlier chronotypes and then abruptly shift later during adolescence, peaking around age 20, 21 for men. So you've probably experienced this yourself or seen your children shift dramatically later during adolescence. And that's something that's seen population-wide. And then following adolescence, we slowly shift our sleep timing earlier. And in older adulthood, people are often actually quite early birds. Sometimes it's a complaint people come to sleep clinic with, not realizing it's kind of the circadian shift that we see throughout the population. You can also note from this graph that during much of adulthood, men have slightly later chronotypes than women on average. So I think it's useful to touch on the transcription translation feedback loop that is core to our circadian clock. So there's a number of genes, clock genes, that are vital to our internal clock. And to highlight a few of these, we have PER and Cry2, whose transcription is activated by a heterodimer called clock and BMAL. When transcribed, they then heterodimerize, come back and inhibit clock and BMAL. So they're inhibiting their own transcription. Over time, they degrade and then are transcribed again and cycle through this. And this follows a 24-hour rhythm, allowing for our 24-hour circadian rhythm. And you can imagine that mutation in one of these core clock elements that impacted how tightly binding was or how quickly these are degraded could influence one's internal rhythm or the period of that rhythm. And we do see that. So at the extreme ends of the normal distribution of sleep timing, we can actually see single gene mutations that lead to these circadian phenotypes. So for most people, it's a contribution of many different small genetic variations that are contributing to our phenotype. But in a few families that have been described, single gene mutations can do this. So this is a family that actually colleagues here at UCSF worked with when they were in Utah 2 decades ago. This woman came to sleep clinic, complaining of waking up very early. She had always been an early bird. It hadn't bothered her, but as she got older and older, she was getting progressively earlier and earlier. And now was finding that she was tired in the afternoon and awakening at 2 a.m. She also noted that this extreme early bird tendency ran throughout her family. So you can see here, this is a pedigree of the family with the black circles and squares noting affected individuals. And this trait was passed down in an autosomal dominant pattern in this family, this extreme early bird trait. And the team went on to describe a mutation in the PER2 gene. You can remember that that's a core clock gene, had been described in animal models, and with this family was described to influence the clock in humans as well. So these are traits in most individuals that are neither positive or negative necessarily. But sometimes people are upset about these sleep traits. So what's the difference between simply a trait and a disorder? It becomes a disorder when someone complains about it, when they are upset by what that pattern, or the impact of the pattern on their daily life. So an individual with delayed sleep-wake phase disorder often complains of trouble falling asleep and trouble waking up in the morning. So if somebody has this delayed sleep pattern but has found a job where they awaken at noon, go to work at 2, and aren't bothered by this sleep pattern, then it wouldn't be a disorder if they were feeling that their sleep was adequate, refreshing, feeling satisfied with the situation. But very commonly, individuals have to wake up for school or work, aren't able to fall asleep, and are getting inadequate sleep with a delayed schedule. Advanced sleep-wake phase disorder, individuals are less likely to come into our sleep clinic and other sleep clinics compared to those with delayed sleep-wake phase disorder. We have a society where we say the early bird gets the worm, and many people aren't bothered by having slightly earlier time to bed and earlier awakening. But it can get quite extreme, as I described for the woman in the PER2 family. And thus we do see people coming in complaining of evening drowsiness and early morning awakenings. Especially as people age, these traits can become more disruptive. Because as you recall, as a society, as a population, chronotype shifts earlier. So this is a 17-year-old, this is a sleep diary that she provided. And she complained of trouble falling asleep. And oftentimes when people have complaints and there's concern for insomnia or a circadian rhythm disorder, part of the evaluation in sleep clinic is a sleep diary. This is the sleep diary the American Academy of Sleep Medicine has available on their website. And you can see it includes shading when sleep occurred, a line when getting in bed, and then noting down when medication or caffeine are used. And of course, noting the dates and the type of day. So you can see that this individual is often getting up at the same time, potentially by alarm, but some days sleeps in much later. She's not falling asleep typically until early morning hours, 1, 2, 3, 4, and thus on many days not getting very much sleep. So how would we treat someone who had delayed sleep-wake phase disorder as this 17-year-old does? So this is a schematic of the common treatment approach. So as we've discussed, light is so vital to telling our brain what time of day it is. So a common recommendation is getting good sunlight in the morning hours, at least 30 minutes immediately upon awakening. Sometimes sunlight isn't easily available. Someone says getting outside is just unrealistic. while they may try to sit by a window that likely isn't quite as strong, or it certainly isn't quite as strong. And so a light box can be a substitute. And this is a picture of one example, but there are many different types of light boxes that can simulate sunlight and be used in the indoor setting. While 30 minutes is a common recommendation, there are certainly individuals where it's not adequate, and more light, several hours of light in the morning, or even an alarm light box that actually starts before waking can be used. And then, of course, thinking about exposure to light in the evening, it's very important to have dim light in the evenings. And so we recommend turning down lights and avoiding bright light, even sometimes wearing these orange or red tinted glasses that can block blue light for individuals who are sensitive to evening light and have a delayed sleep period. And finally, an important component of treatment is low dose melatonin. Melatonin is not as strong as light, as we discussed, to shift circadian rhythm, but it can be used, traditionally given 5 hours before natural sleep onset. And as you recall from the phase response curve to light, that allows it to have maximal input on circadian timing. So depending on the situation for the individual, it often works well to start at someone's habitual sleep timing and then slowly shift their sleep timing earlier by approximately 30 minutes each week, using light in the morning and dimmed evening light and melatonin to help move that sleep period earlier. Not pictured here and not as well researched is the importance of timing of exercise, social interaction, and meal and any food intake, in fact. And those should also be timed to march earlier and correlate with the timing of the sleep period. You can actually have internal desynchrony. If you're eating during the period where your brain thinks you should be sleeping, you can get your gut on a different clock than your brain, and that's actually been shown to have negative health consequences, increased risk of glucose intolerance, for example. This is another patient, a 42-year-old woman who came in complaining of evening drowsiness. She wasn't able to stay up with her children and partner in the evenings as easily as she'd like to. So this is actigraphy, as we looked at before, medical grade Fitbit showing activity and light patterns, and is used to approximate sleep timing. So you can see that she's going to bed between say 8, 7:30 and 9 or so, and getting up around 6, around 3 on some days, up to say 5, 5:30 other days. So her timing is shifted earlier, and she was found to have advanced sleep-wake phase disorder. So let's talk about what we might do to treat this condition. So if you remember the phase response curve to light, our goal for someone with advanced sleep-wake phase disorder is, in fact, to delay them, to help their brain think that the day continues on and that the habitual sleep period should be shifted later. So actually, for these individuals, we focus on light in the evening. I think many people have read a variety of articles about sleep in the popular press and think that light in the evening is inherently dangerous or evil. And certainly many of us are sensitive to evening light, don't get adequate light at other times, and it does delay us. But for this population of patients, we can actually use evening light for therapeutic benefit. So while the exact timing and duration still needs better research, often a recommendation of 30 minutes of a light box in the final hour or 2 hours of the day can help shift the rhythm later. And then avoidance of morning light may also be useful, though that's not been as well researched. So what is the actual risk associated with sleeping at an adverse circadian time? So the group of individuals who this has been best researched in are shift workers. And you've heard a small amount about shift work in the other talks today. So about 20% of those in industrialized nations do some sort of shift work, as defined by work which requires you to be on during periods that you would traditionally be sleeping. And the exact prevalence of shift work disorder isn't clear because many people don't come in to actually complain about it. as they attribute their dissatisfaction with sleep or with ability to stay awake during work or during hours awake with their shift work. But there have been a number of negative health effects associated. I'm not going to go into all of them, but I think this highlights the impact on cardiovascular disease. So this is a large meta-analysis where they found that shift work does increase the risk of cardiovascular disease, including coronary heart disease, myocardial infarction, and stroke. And so those who do shift work, we know they get less sleep. If you're trying to sleep at an adverse circadian time, for example, someone who works overnight trying to sleep during the daytime, they aren't going to be able to get as much sleep typically. So as you've heard about the negative health risks of shorter sleep, you may think that, is this effect actually about shift work, or is it solely about not able to get adequate sleep? And that's what's driving this. So that's a great question and something others have been wondering too. This study from about a decade ago, I think highlights the impact well, that it's not only about sleep duration, but also about shifted sleep. So here, 26 healthy individuals underwent a protocol where they had sleep restriction. They were given only 5 hours opportunity to sleep daily for 8 days. And there were 2 different groups. There was the overnight group, those who are allowed to sleep overnight in a manner that's aligned with their typical sleep and with their typical internal rhythm. And then a group that was delayed. They were forced to sleep 8.5 hours out of alignment. So the 2 groups had similar sleep duration. That's because they were sleep deprived. If you didn't sleep deprive them, we would likely see differences in duration between the 2 groups. And it was shown that those who had circadian misalignment and short sleep had greater metabolic impairment. So a decrease in insulin sensitivity in this group who had the circadian misalignment. Also an increase in CRP as compared to the group without misalignment. So the thinking is that both shorter sleep and circadian misalignment contribute to the negative health outcomes associated with shift work. So the final area that I think is really important to touch on when we think about sleep timing is sleep regularity. This is actually a relatively more recent area of focus within sleep research. There's been quite a lot of work on sleep duration and the negative health impacts of long and short durations. But now there's increasing research on sleep regularity. And the National Sleep Foundation came out with a consensus statement just last year, sharing that consistency of sleep onset and offset timing is important for health, safety, and performance. Nonetheless, when insufficient sleep during the work week occurs, catch-up sleep can still be beneficial. And I want to share a couple specific studies to highlight what's been shown recently about sleep regularity. So in this study, this was a population study of individuals in Tennessee, and actually they included a nice demonstration of what it can mean to have sleep irregularity. So this are just 2 example individuals are sleeping approximately the same duration in total. However, exactly how much sleep they're getting each night is not the same. So the individual in red has approximately relatively stable duration of sleep, whereas the individual in blue has a lot of variability. From day to day, the sleep duration varies quite a lot, despite it being a similar time overall. So this study showed, at least in a population sample, that greater variability in sleep timing correlates with a number of health problems, including neurologic problems, breathing problems, pain, gastrointestinal disease, and depression. This is another study looking at sleep regularity and cardiovascular disease. So they had over 2,000 patients and they had them wear a wrist actigraphy. And they looked at a number of measures that are considered subclinical markers of cardiovascular disease. And they did show that coronary artery calcium scores were significantly worse in individuals who had irregular sleep duration as compared to those with regular sleep duration. And then the final study I wanted to show was one around mood, because this is pertinent to mood as well. So this study looked at 50 individuals considered high risk for suicide, and they followed up with them prospectively at 7 and 21 days and repeated a suicide assessment, and saw those who had greater sleep irregularity had greater suicidal ideation at follow-up at both time points, with the thinking that potentially sleep irregularity is a marker of greater suicidal ideation. All of these are correlation, but it's possible that these are modifiable risk factors, something that we can intervene on. So in conclusion, there is no single right time to sleep for the entire population, but there may be a right time for your body. So learning to understand what is your internal rhythm and work with this rhythm. So you can plan work and exercise accordingly. If you're a morning lark, doing your hardest work in the morning, or hardest exercise in the morning. If you're a night owl, you may plan to have your larger focus period later in the day. And sleeping at the optimal time for your body is something that's controlled, or what is the optimal time for your body is controlled by genetics and the environment. So thinking about the impact of light is really vital. And what is your light exposure? Are you getting adequate sunlight during the daytime? What is your indoor light exposure in the evenings? And for many, dimming evening lights can actually have a positive impact on ability to fall asleep at night. Other things like eating in sync with your timing is important and really needs more work, but we do know that internal misalignment can be detrimental. And then keeping the timing of sleep regular day to day clearly is quite important for not just sleep, but for many components of health. So that is all. Thank you so much for listening.
Thank you so much. That was great. And since we're running a little ahead of schedule, I think we're going to just push straight through to the panel and then give people a little bit of extra time at the end of the day on their Friday, which I'm sure no one will have problems with. So if everyone could go ahead and get ready to answer some questions. And Vivek, I'm going to give you a warning. The first one is for you. So you said after 2 weeks of sleep deprivation, animals die. So we don't do this type of research in humans. Do we know why animals are dying?
Most of it is obviously it's not known because they just wanted to study this population. But obviously, there's this whole inflammation pathway that gets upregulated. The anti-inflammation pathways get downregulated. So one thought maybe that there's just too much, or there's too much energy consumption because of prolonged wakefulness. I think the animal society will not allow us to do those kind of experiments anymore.
Seva, do you have any additional thoughts on that?
Yeah, I agree with Vivek. It's inflammatory. There was some notion that maybe because it was some of these models, they were associated with forced exercise. They were, some of these models, so they were just put on the wheels, and it's several experiments, right? There's a classical RNK experiment. Basically, as Vivek talked about it, there is a energy, basically the energy disbalance. They wasted more energy than with the sleep deprivation rather than consume. So, but and systemic inflammation is an outcome, and wasting. Yeah.
Any other thoughts on that? All right. Liza, you're the next question, but obviously I will open this up to everyone. What amounts of irregularity was correlated with health issues? Namely, what or how many hours or minutes of variation counts? Like, how far off do you need to get before this starts being a problem?
Yeah, I actually don't know the exact answer to that, and I'm not sure if anyone does. I think it's an area that people are starting to look at, and actually the variation has been looked at in a few different ways. There's variation in your timing, right? If you are sleeping 8 hours, but it's at different times, there's variation in your, so that people may be looking at mid-sleep point and seeing the variation there. There's variation in the duration of your sleep. The variation in bedtimes, variation in wake times. I think there's actually a number of different parameters, and I think we have a lot more to learn about exactly what it is we should be paying close attention to. So I don't know what counts at this point in time, but I think trying to anchor sleep at a relatively stable time is beneficial, but we can't say exactly what that is.
Any other thoughts on that?
I think one thing that could be cool to think about too is the variability in sleep and everything is starting to be seen as a predictor of disease onset. And like Dr. Ashbrook may disagree with me, but I think that's a cool place where the field is going that I think might be interesting to look at.
Yeah, absolutely. I mean, this is potentially something modifiable, but maybe it's in fact a consequence, right? These are correlation studies, those last 3 studies we talked about. So absolutely, it could be a disease marker, and it probably is in some cases.
Just makes it all the more difficult to study, right?
Just gives us more questions to answer.
There you go. More fun research to do. I like that. All right, Lauren, the next one is to you. If pain medication is administered, does that impact the lymphatic system?
It's a fantastic question. We've done a lot of work with anesthesia and how that might affect the lymphatic system. We've done some work with somnolence and how that might affect the lymphatic system. Basically, we've been finding a fun correlation between how the drugs affect neuronal firing with how all the fluid can get into the brain. And there was actually 2 recent papers that just came out in Nature that are asking how neuronal firing may change localized clearance in the brain. And one says like 40 hertz stimulation is really great for the cortex, and the other one says it doesn't matter what it is as long as it's synchronized in the hippocampus. And so my answer would be, yes, drugs probably affect lymphatic clearance, but there's starting to be this idea that it may affect region-specific clearance, which could be fun.
Very interesting. Anyone else have any comments on that? To be determined.
Mhm.
All right, Seva, next question, I'll start with you. Is the hypoxic burden greater for patients with compromised medullary reflex center, like in Arnold Chiari malformation?
Yeah, that's a good question. Well, that's obviously unknown. It requires, it depends on severity of apnea. Patient with Arnold Chiari, they predisposed to both central and obstructive apnea, and degree of desaturation usually is in this patient depends on 2 things: how profound their dislocation or herniation is. That's basically is dislocation of the medulla essentially to the spine, right? So, and depends how profound it is. And secondly, it depends also on their weight, because if it adds to obesity, then the obesity is added on the top of it, they desat more. So basically, short answer is I don't know. Long answer is it depends on both severity of malformation and comorbid conditions.
Anyone else have comments on that? I thought that was a pretty good answer. That was a complicated question. All right, Vivek, next question. I'm going to start with you. How does waking up to go to the bathroom affect sleep, and how can you reduce this sleep interruption?
It's lots of sleep continuity, just like many other conditions where, physical conditions which can disrupt sleep, not sleep conditions like sleep apnea, which is also kind of a sleep deprivation. But, people who have asthma, cough during the night, that interrupts their sleep. So, bladder issues that wake people up are causing sleep disruption and in a way, sleep deprivation. One thing which is interesting is that sleep apnea itself is also associated with nocturia, and many times people don't realize that, and treating the sleep apnea, which is non-bladder, not the primary source is not the prostate or something else, can also help decrease nocturia. So I hope that answers the question. Yeah.
Any other thoughts on that one? That one's maybe a little more straightforward. Okay, Liza, I'm going back to you again. If brain clearing happens between certain hours and other health factors relate to non-night owl lifestyle, how does that square with figuring out your own circadian rhythm and following it, particularly if it is on the night owl oriented end?
So I'll defer to Lauren about brain clearance happening at certain hours. I mean, we think about it during certain phases of sleep potentially, but that's not time locked to certain hours. It's more about your like sleep need at the time and previous sleep deprivation potentially. So that is not time locked and would happen at whatever time you're sleeping, especially potentially sleeping at a regular time. So hopefully that answers the question, if I understood the question properly.
Yeah, Lauren, you want to comment on that?
I mean, I think part of the question was also like, I don't know, it's fine. There is an underlying rhythm to glymphatic function. So there is a timing component, but it's only explains like 10 or 20%. So I would totally agree with Dr. Ashbrook. Like, if you need to sleep, you will clean the brain. It might be 10% less efficient than when it would normally want to go.
Right. So the most important thing is getting sleep,
Yeah.
preferably restorative sleep, when you can.
Yeah.
Anything related to that? All right, and move on to the next question. Seva, and also probably everybody can comment on this one. Do you have any tips for improving adherence to CPAP, either for patients or for providers?
Yeah, well, I'm sure Vivek will contribute as well. But my answer is, first of all, the main factors is actually a supportive environment at home. This is very critical. This is the first thing. Second is support in the sleep center or DME company, which accommodate with the adjustment of make sure that the mask fits and make sure that patient is instructed how to use it well. It's interesting. The other factors that really do not play much a role, like nasal mask, full face mask, or another thing. And third thing I forgot, make sure your nose works well. So to fix the nose. Somebody, I'm not sure who told me this expression. Fix the nose. No, fix the nose is fix the hose. So that's right. So a hose means the CPAP machine, obviously.
Yeah.
So there's three things. Vivek, anything else?
Yeah, again, as Seva said, many things have been tried. Different, masks don't really make a difference. Psychological component is huge, right? I mean, they have to have support, as you mentioned, both internal themselves, they need to be, ready to use CPAP, and have family support. Like, if they say, oh, my girlfriend is opposed to my CPAP, then, what else can I do?
This is it. Yeah.
Yeah. That's true for so many things. It's true for weight loss, right? It's true for almost everything in life. You need to have support and belonging to really make things last. Any other comments, Liza?
I agree. I think support with those providing it. I mean, we often will change out masks and change out settings. And also I think there's, kind of some motivational part on the side of the patient in terms of feeling committed to actually doing it, which includes the support of the family. If people are trying their PAP machine on once every week, they're less likely to be successful. So certainly we think a lot about that in sleep clinic.
Great. Okay, next time we're going to start with Vivek, but we'll go to everybody. Stress. We've all got stress. How do we deal with the impacts of stress on sleep?
But decreasing the stress. There's no, I mean, that's physiological, right? So, there's good stress and bad stress. So, good stress is important to achieve things, but sometimes it becomes pathological, and then you have to realize that it's going to have an impact on the body. whether it's on sleep or exercise or diet or timing of sleep or whatever, then you have to go back to the basics and say, no, I recognize that my stress is going to impact my sleep, so everything else should at least be the things that I can control should be controlled, right? So if it's light exposure at night, I have to minimize that. If I have to not have my work in my bedroom, I should minimize that, right? So, if stress is not controllable, factors that can be controlled can, don't eat within 2 hours of bedtime, exercise if you can get time, so that, exercise does help sleep. And I don't know if it helps lymphatic clearance. I should have asked Lauren that question earlier. But, so just, follow the simple other sleep hygiene tips. Yeah.
Any other thoughts on that?
Yeah, that's exactly. Stress frequently triggers insomnia, and that's important to eliminate the trigger. But sometimes it's difficult. It depends on life circumstances. But because then it's perpetuated unless the trigger is removed, it's really hard. But so that's what Vivek said. Try to kind of minimize it and eliminate if it's possible. Sometimes people have to change their jobs. It's not like I'm telling everybody to change their jobs, but that's true, and that may contribute. Yeah.
Absolutely. I'd also point out that this sounds very much to me like we need an integrative approach, and we need to look at the whole person. So we can probably drop in the chat the Resiliency and Wellbeing Center worksheet, which will help you work through some of these things, because you really need to be kind of supporting it from all angles. Nutrition, stress, physical activity, your support system, all of that is going to affect your ability to sleep, and vice versa. Sleep is going to affect those other things. So you kind of have to work on every little aspect a little bit, which sometimes can seem overwhelming, but hopefully we've broken that down for you. So we'll put that in the chat. But in a related question, so when we're sleeping, memories are processing, and we also have these dreams. How do dreams relate to memory processing and sleep, if they do at all?
That's a very controversial question. Some researchers do believe that REM sleep, during which we dream, which again is not necessarily true. We can also dream during non-REM sleep. But REM sleep was, some researchers, their work showed that REM sleep was more highly associated with memory consolidation. Other researchers have shown it's just total sleep, doesn't matter what kind of sleep. I gave the example during my talk that people who take antidepressants don't have any REM sleep, or can have very little REM sleep, and yet have pretty decent memory at most times. So again, now going back to the question about so what is dream, and that's an extremely philosophical question. What do we dream? What is the content of dream made out of? I have my own bias, which is that when we have a exposure to a content during the daytime, and that content triggers multiple associations right away, and then 90% of those associations are rubbish and not really related to my after I've processed that content in my brain in a logical manner, I prune out a bunch of stuff that is not needed, or it's illogical. And then how do I get rid of that? I get rid of that during dreams. That's my logic, my thinking about why we dream certain strange dreams. So it's a good thing that it helps prune the synapses, and it helps prune some of the illogical content that we were thinking about during the day.
Any other thoughts on that?
Just a little thing. Yeah, I completely agree with Vivek. Just a little thing. Well, maybe it's not so little. We have to be vigilant sometimes in approach to dreams, because nightmares, especially recurrent nightmares, that may be sign of PTSD, which should be addressed and treated. And as we know now, PTSD can be triggered by all kinds of different experiences. So, and that's, just this point.
Excellent point. Okay. So we got a bit of a follow-up question on the animals dying of sleep deprivation here. They said, actually, my question was about why the animals died with 2 weeks of sleep deprivation. I wondered if EEG recordings or sleep parameter recordings changed in these animals before death.
That's as far as I remember, Vivek, this is Ref Schaff and Kale's paper.
That was a very old 60s
Yeah,
study.
I don't think they
Had
do
EEG.
EEG recording. I don't
Oh.
think so. Yeah, I don't think it's been done.
And probably won't be at this point, I'm going to guess.
Yeah, I don't think so.
Okay, next question. With cannabis and THC legalized in many states and therefore access being greatly increased, how do you see this impacting the quality of sleep? And I'm going to open that up to whoever feels excited about it.
Well, this is a kind of humor me, please. When I walk out from Rose Building, it's so much cannabis in the air, I don't even need to smoke.
Yeah.
Everybody has to be studied. Then what's going to be placebo? I don't know. Stay home, I guess. Sorry.
But you're right, and it's not just that location. I was in Charleston this weekend. Same thing. It seems to be the case everywhere. It's very popular, and do we fully understand what effect, if any, that's going to have on sleep?
There is some cool work looking at PTSD and cannabis to treat sleep disorders. And there's some cool work where they're asking like, okay, what parts of sleep are you trying to treat and what strain of weed are you using, which is a whole other different issue with
Right.
cannabis research. It's federally regulated still, but strains are going crazy. And so how do you actually see what the patient is using versus what's federally? And in Oregon, when I was there, they were actually paying for Ubers to bring people to campus after they had smoked so that they could get the effect in real time. The other thing, like there was a survey going on in Oregon, because I was there like right when weed got legalized. The survey was going around of what sleep problems do you have and which strain of weed do you use to treat it? And it was just people reporting how they've been dosing themselves.
Yeah, I mean, that's most of what's out there now, it seems, is not formally researched information. And so we need much better research. I mean, I certainly, if patients come to me and they're using marijuana and they're benefiting, I don't tell them, that we know of really negative health consequences. But there is some evidence that may decrease stage 3 sleep, similar to benzodiazepines. And so I don't recommend it for patients who aren't, don't come to me using it.
And that's the THC component, correct?
I don't know. I don't think we know well enough. We don't have enough data.
I know I've seen some research showing that CBD does not seem to disrupt sleep architecture, but then you see that it is happening with the medical cannabis, which leads me to believe perhaps it's the THC, but that's not the most precise research either.
There's also like hundreds of cannabinoids.
Yeah, exactly.
The pulmonary side of me intuitively doesnne like when people smoke. No matter what you smoke, it cannot be good.
Agreed.
We're supposed to breathe air, not, and sooner or later something bad will come out of it, like with tobacco, right? I mean, I prefer different routes of the people use different routes of administration.
Yeah, I agree. And when it's recommended in the integrative medicine field, it's almost exclusively recommended for oral use or suppository, never smoking, because there are clearly going to be side effects of that. Now, maybe they haven't been as well established as they have for tobacco, but we can surmise that it's not going to be that different. Good question. How does chemotherapy affect sleep cycles? We know sleep is really important, and it's certainly getting disrupted in a lot of patients who are going through chemotherapy. Is it the chemotherapy or what is going on there?
I know there is some fascinating research. I think it's not the question, but I'll answer you. There is some fascinating research that the outcome of chemotherapy depends on circadian phase when it's administered. I think there was some high-profile papers, and maybe people who know more experts, Elisa or Laura, maybe comment on.
I don't know. have there been like clinical trials? Because a lot of that's in cells right now.
I think something has been done somewhere. I think there's
Yeah,
I'm not sure.
there's some literature, I mean, and not surprisingly, right? Cell turnover happens at certain times of day more than other times of day, depending on the organ and and what the area affected is. So it's not surprising that chemotherapy may be more effective at certain times than other times. But yeah, I think it isn't in an implementation phase yet, but I think there's definitely a growing body of literature suggesting that maybe we're headed there.
Well, that sounds like a bit of a symptom of the fact that we have historically kind of ignored circadian rhythms and just been like, are we doing it during the day or during the night? And I hope that that's good enough. But I think it's pretty clear that that's not good enough for certain things. And it sounds like chemotherapy may be one of those for this type of research.
But going back to the the question, I tell you anecdotally, we had a case just a year ago where somebody came after chemotherapy for breast cancer and swore that she became a night owl after she got chemotherapy. She had never been a night owl before that, and we looked up PubMed and stuff like that to see if there was any known effect of chemotherapy on circadian rhythms, and we couldn't find anything where people have just looked at that. And she just swore. She said, "I'm a night owl ever since I got my chemo."
Interesting.
very interesting. Yeah.
Well, if anyone else out there has other cases of this, then perhaps we could put a case series together.
I know here there's a whole cancer control group that's looking to see how timed activity can improve lifestyle and sleep in patients. So they're working on it here, but I don't know a whole lot about it.
So they're sort of trying to strengthen the circadian rhythm.
That's the idea.
That makes sense. That sounds, I mean, that would be beneficial in many people, as well as people who are going through chemotherapy.
So they are putting, activity monitors on cancer patients and seeing how their activities look and if they can reinforce them.
Excellent. I've got a follow-up question here about nocturia. Anything recommended for mitigating besides the obvious of not drinking before bed?
Look for the cause and treat the cause.
Yeah.
Go to the urologist. Don't drink alcohol. Treat the sleep apnea. Yeah.
Okay, got a question here about melatonin supplementation. How much melatonin supplementation closer to bedtime would have melatonin holdover in the morning? So I'm thinking this person's using it maybe how people typically use it is sort of closer to going to bed. You take the melatonin, and it's really more to help you sleep.
Yeah, I'll start with that one. I mean, I think traditionally we've thought of melatonin as having a very short half-life. But actually just before this, I was with a rep from a company testing dim light melatonin on set and was showing us many, many examples of individuals who've had testing who stopped their melatonin a day or two in advance, but still had maximal levels. So I think it may well be that oftentimes people are getting higher doses than they expect, or maybe that's not perfectly explained why those levels were so high. But in the data that I was sharing, 10 milligrams of melatonin was still having circadian impact in the morning time. And many people feel some kind of hangover effect from even like 3-5 milligrams of melatonin.
I have a question for Lisa, actually. Do you put your patient with diabetes on melatonin or?
Yeah, I know there's a small amount of literature, but I think it's mostly like much higher doses of melatonin. So I'm not aware of anything suggesting that like a low dose melatonin would be harmful for patients with diabetes.
And now we talk about melatonin extended release, which is even worse. People think it's going to have a longer duration of action, but like you said, it's going to have a hangover effect.
Right.
It sounds like more of a marketing thing rather than a science thing.
But I mean, melatonin is lipophilic. It can sit around in fat, right? Yeah, I'm pretty sure it can sit around in fat.
Well, that would help explain some of those lagging from several days effects.
Yeah.
Interesting. All right. Well, that is basically all the questions that we have, unless any are coming in now. So if that's okay with everyone, I'm just going to go around with final thoughts, and I'm just going to go in the order that we spoke. So, Vivek, please, final thoughts.
To follow the tips that you've learned today. Try to maximize timing, or optimize timing rather, maximize duration. And if you have any thoughts that you may be suffering from a sleep disorder, please come to any one of us or any of your local sleep physicians and get it checked out. Sleep is
Absolutely.
important.
Get professional help. That's always a good advice. Seva.
Yeah, think about sleep apnea. It's very common. If you have it, if you think you have it, come to us, get diagnosed, get treated.
Absolutely. And I can attest that it's not that bad. You do have to sleep somewhere else, but it's just one night. Lauren.
I think I would like to remind the idea that sleep is important for brain health, but also things that are going on in your body other than sleep can impact how you sleep. And so if there's something wrong, get it addressed, because pain or stress can impact how you sleep.
Excellent. And Liza.
Sure. I will reiterate some of what's been said. I mean, as I discussed, sleep timing and following your body's cues about what's best for you on duration and timing is vital. But if you're really dissatisfied and you're having a lot of complaints, seeking out help. And there's a lot of sleep medicine folks out there who can provide guidance. And I suppose to address, I think there was, maybe I didn't fully address the question about figuring out what is your own timing. Sometimes you can follow your body cues and determine that, and sometimes it's less clear. There's a few questionnaires out there that people find useful. The Munich chronotype questionnaire and the morningness eveningness questionnaire by Horn-Osberg are two that are commonly used in research, but you could apply to yourself to get a sense of your chronotype.
Excellent. If you wouldn't mind sending us that information so that Janet could send it out to everyone, I think they would appreciate that. And with that, I will thank you all so much. That was fascinating and I think very helpful. Hopefully people are taking home a few things that they can try themselves that will help improve their sleep or maybe help their patients sleep. And with that, we will end.
Thank you.
Thank you, everyone.
Thank
So
you.
much. Take care.